The Committee on Health, Hospitals, and Human Services is now in session. I'd like to give special thanks, greetings, and salutations to the listening community, to my colleagues, and those present today to provide testimony. As always, we give thanks and praises to the Most High. Blessings. You know, I'm encouraging the current administration to prioritize public health in your funding decisions. This 35th legislature on March 25th, 2024 session, we approved Bill number 35-0207, an act to create the Territorial Chronic Kidney Disease, Stroke, and Diabetes Registry. We'll stand in recess for 1 minute. The Committee on Health, Hospitals, and Human Services were back in session. I'm encouraging the administration to prioritize public health in your funding decisions. The 35th legislature on March 25th session approved Bill number 35-0207, an act to create the Territorial Chronic Kidney Disease, Stroke, and Diabetes Registry. Monitoring these diseases are prudent allocations of our resources. You know, our parents used to say 1 ounce of prevention is better than a pound of cure. On today's agenda, Block 1, which would be from 10 to 11:30, the committee will receive testimony on the public health challenges of managing diabetes in the United States, Virgin Islands, and all the associated health conditions. You know, the statistics will be provided from a local, independent, non-governmental private organization. The presentation will be made by Dr. Julia Sheen. You know, she have a doctor's in public health, master's in public health. She's the executive director of the Virgin Islands Diabetes Center for Excellence. I know her very well, very respected. You know, it's so proud that we have Virgin Islanders like her. She also served as the Commissioner of Health. I think she's a Ban Crucian, but, you know, she's a Virgin Islander, well regarded. You know, diabetes is a chronic disease that occurs either when your pancreas does not produce enough insulin or when the body cannot effectively use the insulin your pancreas produces. And, you know, insulin is a hormone that regulates your blood glucose. Glucose is your body's main source of energy. When your blood glucose high, you know, the people them say you got sugar. Yes, Mr. Vice Chair. Over time, these high blood sugar levels can damage your blood vessels and raise your risk of developing certain health conditions that are life-threatening. So diabetes is important to begin treatment and stick with it faithfully as soon as you get diagnosed. It can lead to limb amputations, onset blindness. Black adults, and this is very important for our community, black adults are nearly twice as likely as white adults to develop type 2 diabetes. And this racial disparity has been rising over the last 30 years. And diabetes is also the leading cause of kidney failure. And here in the Virgin Islands, we have about 219 hemokidney dialysis patients. These 219 patients all have chronic kidney failure. That means that their kidneys cannot clean or filter their blood. So these persons will pass away quickly without kidney dialysis. In simple terms, all these patients have to go twice a week for about 4 hours each visit to get the blood clean. And on St. Thomas, we have 126, and on St. Croix, we have 93. But I want to point out something very interesting here in the community. Of the 126 in St. Thomas, the hospital can only treat 75. So that means Caribbean Kidney Center, a private group, treats 51 patients. On St. Croix, it's very troubling because they have 93 patients, but Wang Louis only treats 40. Caribbean Kidney Center, a private organization, treats 53. So we have more people on St. Croix being treated for kidney dialysis outside of the hospitals. We can't accommodate them. Plus, we have approximately 20 to 30 Virgin Islanders living off island. Some of them left since the storm 7 years ago and they ain't come back home yet. So we still have an issue, but don't despair. We have a plan in place. And basically, the hospitals and the Territorial Health Facilities Corporation, they've been negotiating from since April of last year. They got into serious negotiations, and now we're ready to move where the hospitals will be able to, by adding more chairs, will be able to treat all the patients, all of the 219 kidney dialysis patients. But it's going to cost a little penny, about $5 million. Basically, the hospitals are going to get new chairs. We have to make sure that they're going to be able to get that reverse osmosis system, because when you're getting dialysis treatment, you need clean water. And remember our colleague provided a bottle of brown water and displayed it while questioning WAPA, and WAPA said they wouldn't drink that water. So we can't put that water in our patients as clean water to treat their kidneys and clean the blood. So we're going to get that reverse osmosis purification system. Now that's a big word. But basically, reverse osmosis is a system where you purify the water and you remove the impurities, salts, etc., etc. So I'm asking the Hospital Territorial Board Finance Committee and the full board to review and approve this proposal, then proceed to the OMB director to get her funding approval so we can present this solution to this committee on health, hospitals, and human services, and the committee will have an opportunity to review and vote on this. We have to get this done, people. We have to be able to treat all our kidney patients. We have the plan in place. So thank you, and give thanks and praises to the Most High. Blessings. At this time, Madam Chair, can we have a roll call? Madam Clerk.
Good morning. You can hear me?
Yes.
Yeah. Oh.
Please proceed.
Senator Marvin A. Blyden. Present. Senator Marvin A. Blyden, present. Senator Diane T. Capehart. Present. Senator Capehart, present. Senator Samuel Carrion.
Present.
Senator Samuel Carrion, present. Senator Ray Fonseca.
I'm here.
Senator Ray Fonseca, present. Senator Nobel E. Francis Jr.
I'm here.
Senator Francis Jr. present. Senator Donna A. Fred Gregory.
Present.
Senator Gregory present. Senator Kenneth L. Gittens. Senator Gittens present. Senator Maurice C. James. Senator James absent. Senator Milton E. Potter.
Here.
Senator Potter present. Chairman, we have 8 present, 1 absent.
Thank you, Madam Clerk. We have a quorum. Madam Clerk, is there any correspondence to be read into the record?
No, Chairman, there's not.
Thank you very much. Please read Block 1 agenda into the record, Madam Clerk.
Block 1. The committee will receive testimony on the public health challenges of managing diabetes in the United States Virgin Islands. Invited testifier, Ms. Julia Sheen, MPH, Executive Director, Virgin Islands Diabetes Center of Excellence.
Thank you, Madam Clerk. Can we start with a mic check so that we can make sure that machine, can we, and I'd like to also recognize the presence of Senator Maurice James on St. Croix. So, Madam Clerk, can you give the updated roll call? That's a full quorum. Thank you. Machine, can we have a mic check?
I'm not sure that it's, okay, it's on.
Yes, okay, thank you.
Thank you.
Welcome, Machine, and you can proceed with your testimony. And before you start, I am so enthused about this testimony that you're about to give the public. You may proceed.
Thank you so much, Senator. Good morning, Honorable Senator Ray Fonseca, Chair of the Health, Hospital, and Human Services Committee, Senator Kenneth L. Gittens, Vice Chair, and other members of the Health, Hospital, and Human Services Committee. I would also like to recognize Senator Nobel E. Francis Jr., Senate President, and Senator Marvin A. Blyden, Vice President, and other members of the 35th Legislature of the U.S. Virgin Islands. Good morning to the listening and viewing audience. I am Dr. Julia Sheen, Executive Director of the Virgin Islands Diabetes Center of Excellence. And joining me today is the Chair of VITCO's Board of Directors, Mr. Ray Fonseca. Our Medical Director, Dr. Anthony Oliva, couldn't be with us this morning. He had an emergency procedure last night. Our endocrinologist from Howard University, Dr. Gail Nunley-Bland, our ophthalmologist, Dr. Yan Tin Alvin Liu, and Carlos Casilla, our nurse practitioner. And we should also have online our registered dietitian, Mrs. Sumi Tohan. I would like to begin today's presentation with an introduction of myself for those of you and members of the community who don't know me. I would also like to thank Governor Albert Ryan for his support of the center, as well as Senator Nobel Francis and members of the 35th Legislature for including VITCO in the 2023 miscellaneous budget.
Can we just make sure those that are on video are also present? Can we just do a mic check for those? Media?
Should I continue or should I wait?
Hold a second. I want to make sure that those that are present by video teleconference is available. Media, can you do a check? Okay. You may proceed. Media, just let me know when you get them up. You may proceed, Dr. Sheen.
Thank you. Once again, I am Dr. Julia Sheen. I was born in Washington, D.C., and raised in the Virgin Islands, specifically on the island of St. Croix, all my life. My parents are John Sheen and Angela Hodge Sheen. I come from a large delegation of Hodge family members on the island of St. Thomas, Hendricks and Sheen family members on St. Croix. I'm a proud graduate of the St. Croix Central High School, class of 1987. I obtained my Bachelor's of Science degree in Management from Morgan State University, a Master's degree in Public Health from Emory University, and a Doctorate of Public Health from Morgan State University. I have over 25 plus years of experience in public health. As a Governor Bryan's policy advisor on health and human services, where I led 9 of the governor's Healthier Horizons initiatives. I drafted the telehealth legislation in partnership with Senator Maurice James and Attorney Sincera Cannon. I developed the Office of Health IT, which stood up the Health Information Exchange Project Management Office, drafted successful policy, freedom of choice for Medicaid members, which now allows all Medicaid members to receive services from all providers who accept Medicaid, and launched the association health plans that provide affordable health insurance coverage for small business owners, and much more. I served as a deputy director with the Bureau of Primary Health Care, Health Services and Services Administration, where I had oversight of $100 million in health center funding and received HRSA Administrators Awards for leading the development of a national clearinghouse for training and technical assistance that assists all health centers nationwide, and developing a training program for health center project officers. As a branch chief of the Division of Behavioral and Public Health, I had oversight of $56 million in federal grants, managed 6 national programs, and led the White House Now is the Time initiative, which sought to improve behavioral health services for at-risk children. I served as a public health advisor for the Office of Minority Health's National Partnership for Action, where I provided strategic direction and technical assistance for over 300 regional health equity council members, and had oversight of over $79 million in federal funds. As you can see, I held a series of responsible public health positions, culminating in the role of Commissioner of Health under the DeYoung administration. In this role, I led the passage of the Smoke-Free Act to ban smoking in public places, led Medicaid expansion, which increased the number of members served from 12,000 to 30,000 today, implemented the first Medicaid management information systems, which is still in existence, and led the public health response to H1N1 and dengue. I also served as the principal and owner of JSA Consulting LLC, an EDC company, the only professional grant writing company that secured over $5 million in federal and private funds for government and nonprofit organizations. I have conducted original research in diabetes and will be presenting my research at the largest conference on diabetes sponsored by the American Diabetes Association in June. At this time, I would like to provide some background on diabetes. The World Health Organization defines diabetes as a chronic metabolic disease categorized by elevated levels of blood glucose, which leads over time to serious damage to the heart, blood, vessels, eyes, kidneys, and nerves. So if you answered no to any of the following questions, is your body making insulin? Is your body making enough insulin or using insulin efficiently? Then you might have diabetes and should visit our Vidco office located at 4040 La Grande Princess in Christiansted, St. Croix, or your private provider for further testing. Diabetes is diagnosed through an hemoglobin A1C test, a fasting plasma glucose test, or an oral glucose tolerance test. If your A1C is below 5.7, it is considered normal. If it is between 5.7% and 6.4, then you are pre-diabetic. And then if your hemoglobin A1C is over 6.5 or greater, then you have diabetes. There are three main types of diabetes. Type 1 diabetes, which is called the autoimmune disorder. This is when the insulin-producing cells are destroyed. It's most common in children and adults, and about 5% of the population have diabetes. Type 2 diabetes, or insulin resistance, is more common among adults and children who are overweight. About 5,300 children and adolescents nationally, ages 10 to 19, are affected. Gestational or pregnancy-related diabetes is more common among obese women and may lead to type 2 diabetes. And then there are other types of diabetes that are caused from specific genetic conditions, surgery, drugs, malnutrition, infections, and they account for about 1 to 5% of all diagnosed cases. Up all the symptoms. There are some symptoms of diabetes may include frequent urination, increased thirst, weight loss without trying, blurred vision, numbness and tingling in the hands or feet, fatigue, very dry skin, sores that won't heal, and frequent infections. Managing diabetes is no easy task. It requires daily monitoring of one's blood sugar, exercise, maintaining a healthy diet, medication, and stress management. As Senator Fonseca said earlier, if you don't manage your diabetes, there may lead to severe complications from death to blindness, heart attack, kidney failure, stroke, dental problems, amputations, pregnancy complications, nerve damage, and the list goes on. Diabetes is a silent epidemic, and it has global, national, and local significance. The World Health Organization reported that 537 million people worldwide had diabetes, with the majority living in low and middle-income countries. 1.5 million deaths are directly attributed to diabetes each year. Both numbers and cases and the prevalence of diabetes have been steadily increasing over the past few decades. The global diabetes burden accounted for $966 billion in annual spending and 6.7 million deaths in 2021. And 643 million adults are expected to be affected by diabetes by the year 2030. Nationally, diabetes is the seventh leading cause of death, affecting 38 million people with an annual cost of $412.9 billion, and there was an estimated 1.2 million new cases diagnosed in 2021. In the Virgin Islands, diabetes is the sixth leading cause of death. The prevalence of diabetes is 14.9% compared to 12% in the United States. If you were to put that within the context of our current population, we have over 12,000 people living with diabetes. More females than males were diagnosed, and because we're a predominantly African Caribbean community, it puts us at highest risk. The prevalence of diabetes is particularly high in the Virgin Islands because of our risk factors. 71% of our population consume less than 5 or more servings of fruits and vegetables on a daily basis. 57% of us do not engage in at least 30 minutes of moderate physical activity 5 or more times per week. 35% of us are obese, and 31.8% of us also have high blood pressure. The Virgin Islands Diabetes Center of Excellence was developed to provide support for people with diabetes. Our vision is to become a leader in diabetes education and treatment in the Virgin Islands. We are a 501c3 nonprofit organization headquartered at 4040 La Grande Princesse in Christiansted, St. Croix. We're right across from the James Memorial Funeral Home on the second floor. Our mission is to prevent diabetes and reduce its complications through health promotion, patient education, treatment, and research. Our goal is to reduce the burden of diabetes and improve the quality of life for individuals living with diabetes and those at risk for diabetes. VITCO takes a patient-centered approach to providing healthcare services for our diabetic population. We combine clinical services with education, enlisting family and friends to support our patients, and we connect our patients with community resources. We are building a multidisciplinary team of providers to serve our patient population. We now have Dr. Nunli Bland, an endocrinologist from Howard University, who sees both children and adults. Our ophthalmologist, Dr. Alvin Liu, from Johns Hopkins University, will screen our patients for diabetes retinopathy, and our nurse practitioner, Mr. Carlos Casillo, who conducts head-to-toe assessments, and our medical director will oversee clinical operations. We also have Dr. Ava Roberts, a podiatrist, joining us in the summer to perform foot exams. We are building a patient-centered medical home for persons with diabetes. VITCO services consist of our rural health outreach program, where we go out into the community and conduct rapid A1C testing to identify new cases of diabetes and those persons whose A1Cs are out of control. We recently procured a telemobile unit to increase access to these types of services. VITCO's clinical services are also offered in person and via telemedicine and include consultations with the specialists I mentioned earlier. Our chronic care management services is where we follow our patients every 3 months to include them in interventions that help them control their condition. We recently held a medication management session with GVI employees, and it was well attended. We are expanding our footprint in this community with outreach education and awareness activities. Over the past 6 months, we have conducted and participated in 15 outreach events. We conduct monthly diabetes self-management classes and will launch a 12-month program for people with prediabetes in June. This is just an example of some of the events that we've participated in. VITCO's partnerships continue to grow. We currently partner with the Department of Health, University of the Virgin Islands, Beeston Hills, Health and Wellness, Howard University, several churches on the island, and we just recently formed a partnership with Amazon and Square ML. VITCO's weekly schedule consists of clinical assessment and rapid A1C testing Monday through Friday from 9 a.m. to 5 p.m. We're moving to comprehensive lipid and cholesterol testing in-house within the next month. The diabetes self-management classes are offered once a month on Tuesdays from 4 to 6, and endocrinology services are provided on Wednesdays and Fridays. VITCO's diabetes self-management classes are customized based on each patient's needs and goals and life experiences. These classes promote healthy eating, increased physical activity, teaching skills to monitor blood sugar, medication management, and how to cope with stress. VITCO's staff has over 100 years of combined experience in endocrinology, nutrition, pharmacy, public health, family medicine, etc. VITCO's core team consists of Dr. Anthony Oliva, I can't point to him, Dr. Anthony Oliva, who is our medical director, Dr. Nunli Bland, who is the endocrinologist, Dr. Yan Ten Lu, ophthalmologist, Sumi Tohan, the registered dietitian, Carlos Castillo, a nurse practitioner, Desiree James, the nurse educator, and myself. VITCO is governed by a 7-member board of directors which consists of Mr. Ray Barry, chairperson of the board, Tatia Monell Hewitt, who is our treasurer, Janine McFarland, she is our secretary, Donna Christensen, Colin Hodge, and Dr. George Rosenberg. VITCO continues to grow its target population, and the next few slides will provide an overview of our patient demographics. To date, we have served 1,600 community members. Most of the individuals we've served have type 2 diabetes, or 77%, followed by those with prediabetes at 21.3%. 68% of our population also have high blood pressure, and 41% have high cholesterol. nearly 80% of our patient population are overweight, and 50% are obese. Our target population is people with type 2 diabetes, children and adolescents, and men. We would like to do more work in our schools as well to try to prevent the onset of diabetes, particularly among children who are overweight and obese. The diabetes continuum of care, which is our main focus because we want to address diabetes more comprehensively. It optimizes provider and multidisciplinary team interventions by promoting the national standards and increasing access to diabetes specialists. We also facilitate behavior change in individuals that are at risk and those that are living with diabetes by incorporating the use of community health workers to provide support to our patients. And we focus a lot on lifestyle and management skills, promoting physical activity and healthy eating. We're also focusing on improving health systems and the interventions that incorporate behavioral health counseling and the use of health information technology. We are also reducing health disparities and addressing the social determinants of health. And for us, it's all about measuring outcomes. There are some of the examples, these are some of the examples of the key indicators that we measure and that we are incorporating into our systems. Things like reducing A1Cs for all our patients, making sure that they're no greater than 7, improving dietary habits, improving physical activity and increasing access to specialists, as well as improving and helping people lose weight. We follow 200 patients over a 6-month period. We monitor their blood sugars and provided diabetes self-management classes, exercise classes, and nutrition counseling. We found that 62% of those patients saw reductions in their A1C. It proves that VITCO's business model works and it's making a difference in the lives of our patient population. Since VITCO's inception, we've accomplished a lot. I would like to close my presentation by sharing a high-level summary of those accomplishments. We served 1,600 persons with diagnosed diabetes, whether they had prediabetes, hypertension, or high cholesterol. We had over 250 people participate in our diabetes self-management classes. We became a CDC recognized prevention center last year. We're partnering with Howard University. We recently recruited an ophthalmologist from Johns Hopkins University to screen our patients for diabetes retinopathy. We partnered with United Healthcare last year and their wellness fair on September 26th on St. Croix and 28th on St. Thomas, and we saw over 600 people. The Department of Health, we partnered with them to develop a diabetes preparedness plan, and we had a meeting with our local pharmacies to do that. We launched our billing services on December 5th, 2023. As I mentioned earlier, we are involved in ongoing outreach and education and awareness activities. We applied for and received 4 new grants. We also implemented a MOU with St. Thomas East End Medical Center and established a referral relationship with Frederiksted Healthcare, Inc. We are getting ready to launch a 12-month mixed media campaign in partnership with UVI. We identified a new location for our office here on St. Croix, one that is ADA compliant, and we are in the process of finalizing our lease for our St. Thomas location. We are partnering with the Division of Personnel to promote health and wellness among GVI employees, and that's an ongoing partnership. We are preparing to launch a summer camp for children with diabetes. We are launching our pre-diabetes class, which is a 12-month program for persons with pre-diabetes. And we will be bringing in a telemedicine mobile unit, hopefully in June. One of the most significant accomplishments is the fact that we are launching a facilities-based diabetes registry in May. That registry will collect information on demographics, vital signs, cardiac and renal elements, track annual eye, foot, and glycemic control. It'll also track the social determinants of health, patient education, service utilization, risk stratification, and it will have an app for our patient population. I would like to close if Mr. Brown could bring up the patient testimonial, and thank you so much for providing me with the opportunity to share this information. Mr. Brown?
Yes, proceed, Mr. Brown. We don't hear them. I show that we have 5 persons on Zoom. Mr. Ray Barry, whom I know very well, Alvin Liu, Gail Bland, Carlos Castillo, and Sumi Toham. Are those persons available, media?
Yes.
Yes, if you could just say yes, we want to make a mic check for everybody.
Yes.
Yes, President, this is Ray Barry.
Yes, this is Dr. Gail Nunley Bland.
Yes, thank you.
And we can't hear the video over here.
You had additional testimony, or that
Yes,
concludes?
I have just one patient testimonial that
Okay,
we're
yes,
not able to hear.
proceed. Somehow we can't hear them, so let's check it out and we'll get back to that. Well, you heard it, folks, in the community, the testimony. Sharon, I see a visual. Go ahead. Yes, proceed.
Edco, Virgin Island Diabetes Center of Excellence, and I had started with a diabetes number A1C of 6.8, and today went down to 6.2, girl. If you have any issues with diabetes, pre-diabetes, anything like that, come on over to Vidco and get your numbers down.
Thank
Thank you, Senator. That concludes my presentation.
Thank you, Dr. Sheen. And folks, you heard it from Dr. Sheen. It costs the nation $412 billion to treat diabetes. Well, Sapopa, see money day. But you know, we only asking the VI government for $4.9 million to deal with our diabetes. As a matter of fact, I just got the updated numbers on St. Croix, And there's actually now 60 patients in St. Croix that are treated by CKC and only 42 by the hospital. So the numbers are actually worse on St. Croix than it was last time. But we only asking for $4.9 million, and I'm going to give them the breakdown on that. It's going to be, we need $866,000 to buy 15 new hemodialysis machines and 15 chairs and the reverse osmosis system. We also need staffing, drugs, and supplies. So 1.9 million for Snyder, 1.4 for Wang Louis, and a total of 4.9 million. They got all the little miscellaneous thing in that. So, you know, those numbers, to over 12,000 people in our community are living with diabetes. You see, when we got that number from the Commissioner of Health, she said the same number. But it has a lot more weight now when an independent person that's not affiliated with the government is telling us over 12,000 people right here in the VI living with this disease. So, you know, and of course, one of the things that Machine mentioned is that diabetes can lead to stroke complications. So I'm also pleased to announce that the President of the legislature and I were sponsoring a bill to provide those bracelets for those stroke victims. It's only going to cost about $75,000 because, you know, stroke can kill you immediately. And we need to be monitoring those patients. There's somewhere close to 200 of them that is going to need this, and that will save lives. So I'm proud to announce that the President ICE will be sponsoring the legislation. So, Senators, we're going to go to a round of 6 minutes. Oh, yes, let's do a system check for the mic for Barry. No, that's right, we did. I heard everybody. Okay, so we're going to start with Senator Blyden, Capehart, Senator Francis, Gittins, Senator Potter, Carrion, Senator Donna Fred, and Maurice James. So, Senator Blyden, you're recognized for your 6 minutes.
Thank you so much, Mr. Chair, and good morning to my colleagues, viewing, listening audiences, staff, central staff. Good morning, Dr. Sheen, and thank you so much for this testimony. It's on point in terms of data and information. I see that you are well credentialed and you have many accomplishments. Too numerous to mention, but you were not born in the Virgin Islands, but you definitely are a Virgin Islander, and you're giving back to your community, and we want to thank you for that. In respect to your testimony, right? You have said a lot, but I want to focus honestly on a couple areas quickly: prevention, managing diabetes, and how we move forward in terms of FIDCOR. Let me ask you, in respect to prevention, in your slide, you spoke to males and females here in the territory, and you mentioned that the numbers for females are way, way more in the territory than males. Is there a reason for that?
That could be because, first of all, the data comes from the Behavioral Risk Factor Surveillance System survey that the Department of Health administers. And the reason for that could be because men are just underreported. It doesn't have to necessarily mean that they are not at higher risk, but they might not be reporting that information or participating in that survey.
Very well, because I was quite, troubling to see the numbers, but that can be a symptom of that, that's for sure. Let me ask you though, when it comes to managing diabetes, what would you recommend? Because I want you to speak because this is a very important topic, and I'm glad that we're having a discussion this morning. What it's entailing managing your diabetes if you have diabetes?
Yeah, so I'll start, and then I really would like Dr. Gail Nunley-Bland, since she is a specialist, to really talk about this as well. But I heard one patient say that managing diabetes is like a four-legged stool. You have to monitor your diabetes, You have to cope better with stress, eat healthy, and exercise. And if you're not doing all four, you're not going to be successful in managing your diabetes. It's just not good enough to take your medication. You have to incorporate that with all the other pieces. And so I'd like to turn it over to Dr. Nunley Bland if she have anything to add from a specialist point of view.
Thank you, Dr. Sheen, and thank you for the Virgin Islands legislative body. You spoke very well, Dr. Sheen, about what it is, that it is diet, exercise, stress management, and medications. But I'd like to emphasize how important it is to first make the diagnosis of diabetes early on and manage it appropriately. We talk about those late complications, stroke, dialysis, amputations, blindness, and so forth, which are complications of diabetes. But we do know that we can prevent those, and is that downstream revenue that we have to expend on patients who have not been well controlled really cost our health society more. Just to give you a little background from where I'm coming from, I'm in Washington, D.C., and I started the Diabetes Treatment Center here in DC in 2007 for the very same reason that Dr. Sheen has her VITCO, that we see a large portion of our population, predominantly African Americans, who have diabetes. And the district government wanted to have a program where could provide services for our patients that is comprehensive. And having our nutritionists involved, our diabetes educators involved, our members who specialize in diabetes, we have prevented a lot of those complications. We rarely see our patients on dialysis. We rarely see our patients with amputations. We rarely see our patients with blindness. And so we do know that a comprehensive approach to managing diabetes does work and prevent some of these complications. The other thing that we're very proud of is that we reduce hospitalizations related to diabetes. And so that is something else that is cost saving for our healthcare system. So yes, it is a preventable disease, and we would like to prevent diabetes. And, pre-diabetes is one of those conditions where if we catch it early on, that we can actually reverse it. And that is through diet and exercise. So we do have a long way to go in terms of the prevention. But if we can detect diabetes early, treat appropriately, we can prevent a lot of those complications.
Okay, thank you so much. And in closing, Mr. Chair, in respect to reducing health disparities, and it was spoken to exercise and eating healthy foods, right? But in this category, it speaks to the lack of access to healthy foods, unsafe housing, poverty, lack of safe places to exercise, unemployment, lack of educational opportunities, and social determinants of health. Dr. Sheen, in respect to, let me go to two spaces here in the territory, specifically since you're on St. Croix, the lack of access to healthy foods and lack of places to exercise. Do you see that impacting us here in the territory in any way, shape, or form? And at what level would you say? And
Time.
what do you see that needs to be done moving forward?
Before I respond to that, I do want to address one issue that I heard Senator Fonseca speak to in terms of dialysis and the $4 million that's required to address the dialysis crisis that we have here in the territory. I will say that it will cost about $100,000 a month to provide services to one dialysis patient. But as Dr. Nunley Bland mentioned, if you make an investment in prevention, I can guarantee you that you won't be spending $4 million. And we need to address the prevention piece in the front from the beginning. And so you'll have less people on dialysis, and that's what our center seeks to accomplish. In terms of healthy eating, I conducted original research here in the Virgin Islands in 2018. I looked at the barriers associated with uncontrolled diabetes amongst the health center patients. Many of the patients spoke to the fact that they could not access healthy foods. It's either too expensive or they're just not available. I mean, you go to the grocery store, you buy the fruits and vegetables, you take them home and they're spoiled. That's one issue. And then you talked about physical activity. We don't have enough places that we can safely walk. Not everybody can join a gym, they can't afford it, but we do need to create a better environment so that people can walk. I walk down by the, right across from the rum distillery, Captain Morgan Rum Distillery, and I always wonder why we can't partner with the owners of that park so that we could pave that area, because a lot of people go there. And so we need to be looking into places where people normally walk and trying to improve the infrastructure to make it easier for people to exercise.
Thank you so much for your responses, Mr. Chair. Thank you for your leniency. Thank you.
Yes, thank you, Vice President, Senator Blyden. You know, Dr. Sheen, I don't have a PhD, but I like to do a little numbers thing, you know. So if it costs $100,000 a month per patient, and we have 220 patients, these are the latest accurate numbers, times 12 months, it shows that in the community we're spending about $264 million on this whole diabetes thing. So it's
Dialysis.
the dialysis, kidney
Services.
dialysis thing. Yes, thanks for the correction. So it's very costly for the community. And a lot of these instances are where patients are presenting to the hospital where they have an acute flare-up and thing, and the diabetes, the sugar high, and they go into these acute stages where they have to present to the emergency room, and it presents as the uncompensated care. So folks, prevention is a lot cheaper than the other way where you get to end-stage kidney failure and dialysis. So I'm so happy that you were able to give us this testimony, Dr. Sheen, and I'm so happy to know that the 35th legislature has partially funded you. I think we had a little discussion that your scope has expanded a little bit, so I'll allow you the opportunity to, present the committee your needs.
Thank you so much, Senator. I actually had a meeting with Senate President Nova Francis, and he suggested that I submit my request in writing. So I will be doing that within the next week.
Okay, we look forward to it. Thank you very much. So next we'll go to Senator Diane Capehart. You're recognized for your 6 minutes.
Thank you, Mr. Chair. And good morning, colleagues. Good morning to the people of the Virgin Islands. Good morning to Dr. Sheen. Thank you for your very informative presentation today, because education is very important. And one thing I was thinking about, and you mentioned it about the children and addressing the children to teach them. And it just had me thinking, like, how many children in the Virgin Islands have diabetes?
That's a very good question. Years ago, we used to conduct the Youth Behavior Risk Survey, which was a survey that the Department of Education would lead. And I don't know where that survey is, but it would collect that kind of information. And I certainly could not find any data in the Virgin Islands that collects information on children and risk factors and health habits. So we don't have that information, which I think is very critical. Just finding out the percentage of children who are overweight and obese is critical, because then you can intervene to try to provide more education for them, because they would be at risk for developing diabetes.
And what age would you think would be age appropriate to start educating our children from school and, doing that education in school about prevention. What age do you think that we should start addressing or educating our children?
That's a good question. So studies show that by the age of 10, a child develops their habit. They say if you're going to train your child, teach them all the values and everything before the age of 10. Because by 10 years old, their value systems are already developed. So I would say anywhere from 8 onward, and I don't know if Dr. Noli Bland wants to add to this since she sees both children and adults. It would be nice to hear her perspective about what she's seeing in her clinic and as a provider, what she would recommend.
Now, the intervention for children, actually age 5 to 6 is when we see that obesity rise, and intervention should start at that age. If a child is obese by the time they're age 5 or 6, there is a 50% chance that they will remain obese by the time they're an adult. By the time they're an adolescence, and we're talking about 12, 13, 14, and they're obese, then 90% of the time they're going to remain obese. So the earlier we intervene with obesity, we can significantly reduce them going on to be obese adults. And as we know, obesity is a contributor for diabetes, that we could prevent the diabetes as well.
Thank you. So how long would it take before, how long can a child have diabetes without knowing?
Dr. Noli Bland, I'd like to refer that question to you.
So it depends on what type of diabetes. And Dr. Sheen talked about type 1 diabetes, which has a fairly rapid onset. And so it may be a month before you know that that child has diabetes. But type 2 diabetes, and unfortunately we are seeing children with type 2 diabetes, by the age 10, we actually start screening children who are obese. And by the definition of obesity in a child, we base it on the percentile. If their weight is above the 95th or BMI is above the 95th percentile, we should start screening them for diabetes. And we would do fasting blood glucoses, or we'll do a hemoglobin A1C. And that is the recommendation for diabetes, type 2 diabetes in children.
Thank you. So you mentioned it's a silent epidemic. And, I have to commend my colleague for bringing the registry for diabetes and kidneys. It's very important that we collect this data. So my question is, how much money did the VI Diabetes Center of Excellence receive to operate? Because this is an expensive endeavor.
Very. We received $1.9 million in ARPA funding in 2022. We have about $700,000 of those funds left. And so
how much you have left?
$700,000. And so we will be making a request of about $1.2 million to the legislature.
Okay. And is VI DCOE, you have 501c3 nonprofit status?
Yes, we are.
Okay. I think you mentioned it, but I want to drill down. How much money does it cost for one person to actually spend per month on diabetes? Did I hear you say 100,000?
So I said it costs $100,000 to treat one patient with dialysis.
Oh, dialysis. Okay.
Yes.
So how much would it cost? Just like a estimation, if someone has diabetes, what is their monthly expense?
And let me refer that to Dr. Noli Bland, since she's been running her clinic a lot longer than us. She might have those numbers as well. Dr. Noli Bland?
The average cost for diabetes runs anywhere per year $7,000 to $10,000 per person. And that includes, doctor's visits, screening, medications, and so forth. But yeah, it runs about $7,000 to $10,000 per year per patient, the cost.
Wow. Mr. Chair, if I may just ask one final
Yes,
question.
you may.
Dr. Sheen, you mentioned about a diabetes summer camp this June 2024. I think that's a great thing. Will there be a cost for these children?
Yes, we do have some funding that the legislature provided, but we will charge a registration fee because, excuse me, it is very expensive. Our camp is only going to be a 2-week camp and to start. But it is very expensive. We're going to target 25 children on St. Croix and 25 on St. Thomas. And so there will be some sort of a registration fee, and we're still working out the numbers.
And then just to conclude, if I had diabetes and I can't afford to buy my insulin or the injections, can I come to your facility and say, I have a need and I can't afford this?
Yes, we actually, and the board is considering implementing a sliding fee scale for patients that don't have health insurance, because we do see them in our center and they usually pay out of pocket. And so the sliding fee scale would make it more affordable for them. But as I mentioned in my presentation, we do partner with the health centers, and the health centers have a 340B program. And so we do refer our patients back to the health centers if they're having problems affording their medication.
Okay. Thank you, Dr. Sheen. Thank you, Mr. Chair, for being so lenient. Thank you.
Yes, thank you, Senator Capehart. You know, just to follow up with those numbers, so if it costs $10,000 per year per diabetes patient, and my colleague, the vice president, was telling me it's probably more in the VI because everything more in the VI. But even if we go with 10,000, being that Dr. Sheen told us there's 12,000 patients, that's $120 million just to treat the diabetic patients. Remember, we already said it was $264 million to treat the 220 kidney dialysis patients. Those are the ones with total. So any way you look at it, this is a lot of money. I also wanted to follow up on one thing, right, that Dr. Sheen was mentioning, right? When the child is obese, no, I don't think it was Dr. Sheen, I think it was Dr. Bland. After age 6, the chances are very high that they will develop this childhood diabetes and things. So if your child eating the chicken and the stuffing and the rice and the macaroni and cheese, that equal diabetes. So we're going to go to the next senator, Senator President Norville Francis. You're recognized for your 6 minutes.
Thank you very much, Mr. Chair. Good morning to you. Good morning to my colleagues. Good morning to the people of Virgin Islands, and of course, good morning to Team VidCorps. Thank you very much for being here, and I certainly appreciate your excellent presentation, Dr. Sheen. And as you have known, we have dialogued many times in regards to these issues that's confronting us as it pertains to diabetes. And every time I see the presentation, I cringe. When we talk about 12,000 individuals in this community, and I believe that's the tip of the iceberg, really. But when we talk about 12,000, that means that 1 in every 4 individuals in a community of a little bit over 80,000 individuals are walking around with diabetes. And those that don't have diabetes have some form of illness somewhere along the line. So we have an aging community, we have a sick community, and I think that when we're having this discussion, yes, prevention is certainly the key as we move forward. $1.2, $1.9 million pale in comparison to what we spend in terms of healthcare in this community. $184 million in healthcare insurance. We spend over $200 million in SNAP programs, and we still talk about having 30% of our individuals living in poverty. And I will suspect that those individuals that's living in poverty also have some issues in regards to diabetes or this whole discussion that we're having here, because when they do have an opportunity to eat, chances are is a lot of sweet, sugary products. So at some point, we're going to have to make the correlation between what is alcohol, what is sugary products, what is fast food doing to this community, and really put in place measures to minimize those opportunities. So I have a couple of questions real quick. There's this notion in our community that the BMI is not for Black people, not for African American individuals. Can you speak to that misnomer as it pertains to the BMI?
I'd like to defer that to Dr. Nunli Bland, talk about the BMI, and that we also have Ms. Sumi Tohan online as well as a registered dietitian that can speak to BMI as well. Dr. Bland?
Yes, BMI. This is a population health statistic. We define BMI of greater than 30 as being obese. But we also know that not only is it the BMI, but where the fat is located. And we know that if you have your fat located primarily in your stomach, waist circumference is probably a more accurate measure in terms of whether you're at risk for diabetes and cardiovascular diseases. So when we talk about waist circumference, if you're a woman, if your waist circumference is greater than 35 inches, or for men, greater than 40 inches, that puts you at an increased risk for diabetes. So these are measures that we can look at, not only BMI, but where is your fat located? And I think Sumi can also speak to that. She's a nutritionist that also deals with this as well.
So my question, as a deeper dive to that, Doc, is in regards to, is there a BMI for African Americans and a BMI for Caucasian individuals? They're all the same, correct?
Well, I think more studies are needed because, BMI also encompasses muscle mass, but I think more importantly, we look at it more where your fat is distributed.
Okay. Very well, I'll move away from that. There was also some comments made by Dr. Sheen in regards to, of course, the pregnancy.
1 minute.
I wanted to ask real quickly, are we seeing a lot of new childbirths or childbirths with diabetes? Are parents then transferring, these illnesses to their newborns?
Dr. Nunli Bland?
Yes. If a mother has gestational diabetes, that increases her child of developing diabetes later on in life. So there is a correlation with gestational diabetes and for type 2 diabetes in their children.
Okay, very well. And I know that we talk about the costs of medication and everything. I just want to say that, just yesterday we spent some time with Senator Warnock, who was instrumental in moving in the 117th Congress insulin cap. So that again, where there's a $35 cap and insulin that's being provided to those individuals. Dr. Sheen, in regards to your comments and recommendation that I'm very much open to have the discussion with the owners of Renaissance and as a government to be able to support perhaps the grading or the build out and making more walkability spaces available for community members. So that's something that I'll take up and really have a discussion with them because, again, any opportunity for us to do that is important. One of your comments also, you spoke about, Dr. Sheen, in regards to the females compared to males. Are you seeing that as a result of what? That they're less, as a result of sedentary lifestyle? Or what is causing that difference in comparison when you look at female versus males as it pertains to diabetes?
I believe that the data might reflect the fact that it's underreported. Men are underreported in the survey. That could be one issue. The second issue could be that more men, are not as astute in taking care of their health. Women are more, they are the caretakers and they are more involved with the health care for their family. So that could be another issue as well. Dr. Nunli Bland, I don't know what you're seeing in Washington, D.C. in terms of male versus female, and if you could elaborate on that.
Well, you mentioned sedentary lifestyle, obesity. Those are factors that are responsible for where we see in terms of diabetes. And I think sedentary lifestyle probably plays an important role in terms of what we see with women as well, as what you've also mentioned in terms of the underreporting of males and in terms of the surveys.
Okay, thank you.
Thank you very much, Mr. Chair,
Yes,
for the
thank you.
time. And again, I'm in full support of this entity and any entity that continue to educate our community in regards to better healthcare opportunities. Thank you.
Yes, thank you, Mr. President. Real quickly, I wanted to go to Mr. Ray Barry, good friend of mine. As a matter of fact, we live right up the street from each other from a long, long time. So concerning prevention, because Dr. Sheen has already outlined how prevention is much more efficient, less costly for the community. What are the goals for the group on prevention strategies for the Virgin Islands Diabetic Center of Excellence? And also, where are you located on St. Thomas?
So I can respond to that, and then if Ray wanted to add.
Okay.
So I talked earlier, excuse me, Senator?
Yes, proceed.
Okay, so I talked earlier about what we're trying to achieve in terms of our services. We do offer what we call rural health outreach services, where we go into the community and we conduct these rapid A1C testing so that we can identify persons that either don't know they have diabetes or people whose A1Cs are out of control. We also provide telemedicine and in-person clinical services in our office. We're currently only located on the island of St. Croix, which is in the Grand Princess, right across the street from James Memorial Funeral Home on the second floor. And on St. Thomas, we're in the process of negotiating a lease right now. And so we hope to be able to launch the St. Thomas location in June. We also follow our patients, what we call chronic care management, to make sure that they are reducing their A1Cs, providing diabetes education, physical activity sessions, etc. And then finally, we're out in the community participating in outreach, awareness, education, various activities.
Okay,
So those are core services. And I don't know if Mr. Barry wanted to add to that, since you wanted to go to him.
Yeah, Ray?
Yes, sir, certainly. Thank you. And good morning, Chair Fonseca and other esteemed senators present. One of the things that I also wanted to add to the presentation is not just the cost of the care, but the impact, the financial impact that it has on workforce, okay? Because if you have individuals that are in workforce, both in the governmental sector and in private sector, that due to their illness are incapable, unable to present to work, or they have situations where they are just disabled for extended periods of time or have to move to dialysis, amputations, and the like, that has a financial impact on the economy of the Virgin Islands, okay? So that also is a factor that I think we also have to consider when looking at the impact of this disease, okay? So I just wanted to add that piece, and obviously, I think Senate President made mention to the cost of the health insurance that the government pays. We see, I've been in the industry for a number of years, and I remember when the premiums were in the range of about $28 million. I don't even know where, I know it's over $100 million today. I don't know what specifically those numbers are, but it has an impact, a financial impact, a direct financial impact to this economy and the people of the territory.
Yes, thank you, Ray. As a matter of fact, yeah, the president mentioned 184, In addition, if you add the Medicaid program, which we spent $120 million, it's actually $442 million with just those programs alone. So any way that you do the math, it adds up, and it's always good to see you, my dear brother Ray. Okay, so one other thing I wanted to ask, because I wanted to ask Dr. Bland, I want to know specifically to compare the Virgin Islands with the United States, because Dr. Sheen mentioned that there's 14.9% of our residents with diabetes. How is it comparable to the United States? How are the majority black areas with the diabetes percentage? We're 14.9. What is it in your area?
So, thank you. I'm glad you brought that up. Now, if you look at our overall rate in terms, and I'm speaking of Washington, D.C., and pretty much the nation, it's about 7% of people with diabetes. But if you break it down based on black individuals, Hispanics, and American Indians, these are the racial groups that tend to have higher rates, it is upwards of 14%. So it's very similar to the Virgin Islands. And in Washington, D.C., in certain pockets where we have the high rates of poverty, the rates of diabetes is 18%. Almost 1 in 5 individuals will have diabetes. So it is based on socioeconomic factors as well as racial factors that we see the higher rates.
Wow, that's incredible. Washington, D.C. is even higher percentage than us. Okay, thank you, Dr. Bland. Vice Chair Senator Gittins, you're recognized for your 6 minutes.
6 minutes for this discussion, this important discussion. I'm not sure how we're going to influence, encourage, whatever word we want to use, people not to eat certain foods or to eat it in moderation. Because when you're hearing of the oxtail and the sauce, the roast pork, and everything, you know, I get a habit, I get my mouth in trouble, but I remember when the chief executive was talking about sluxing and people got upset. But listen to the conversation here today. Let me also start out like the president did and thank Vidco and all the testifiers here with us today. Those of you online, thank you all so much for the information here today and the continued discussion back and forth. You know, as I really sit back and think on this, you know, education is going to be key on this. We must educate our people in understanding what diabetes is all about. I love the testimonial presentation that was shown earlier. The presentation shows the use of one of the facilities in Christiansted on the island of St. Croix up at the lagoon. This tells me that we also need to get the facilities moving on the western end of the island, the Frederiksted Pool. This is why I've been asking for us to do this by phase, because while there is a problem with the pool in itself, fix the grounds so that the people can be able to utilize the property. Do a phase 1, phase 2, and if necessary, a phase 3. But phase 1 should be the facility, the grounds, so that people could be able to utilize the green space and possibly the pavilion. Dr. Sheen also spoke to there not being enough walking space and why we can't partner with the private sector. My question is why we can't invest in ourselves and partner with ourselves by fixing our properties so that our people can have access to these facilities. Again, as I sit here, I'm torn because, again, on the western end of the island, we just tore down Arthur A. Richards Junior High School. On that grounds, there was not only a gym, there was a track that people greatly utilize, tennis courts that people utilize, and we spoke about the young and the old, and a lot of seniors used to utilize those tennis courts. You had a baseball field there, and a whole bunch of other sports that you could have utilized that facility for. So I'm saying we need to invest in ourselves through historic legislation. The Biden administration also passed what is known as one of the largest infrastructure bills that we've seen in American history. We should have access to monies to take care of our infrastructure. Our infrastructure is crucial to not only our health, but also our economic development here in the territory.
1 minute.
We should be utilizing these monies to fix look at the condition of our sidewalks. Even to walk in certain areas. We have put up sidewalks in neighborhoods and in areas where connect you from residential area to business areas, and you can't even utilize the sidewalk because the bushes are overgrown or the sidewalks are in no condition for even a wheelchair to traverse. Colleagues, while we do the appropriation and don't have the final authority to make sure that these things are executed, we need to speak about it and put some pressure where it needs to be. Because we need to be able to provide these services for our people. If we're talking about healthy living and we want people to exercise and walk, then we have to provide the facilities for them. But listening to this diabetes presentation today, it really has me in awe. And yes, gonna make me think about eating certain things in the magnitude that I have been. But lately, I must say I've been a good boy. Slow down a whole lot. And if I could do it, I say anybody else could do it. But again, thank you all so much for this.
Time.
But colleagues, again, let's encourage the administration, all of us to work collectively so that we can invest in our infrastructure, again, which is crucial to our health care and our economic development here in the territory. Thank you, Mr. Chair, for this discussion as well.
Thank you, Mr. Vice Chair. So I gonna watch you, make sure you know sluxing down a little bit later on. But you know, I wanted Carnival coming, yeah. You know, but I wanted to highlight a real important point that the Vice Chair mentioned, right? These public-private partnerships. You know, all of the government agencies come here before us about their money issues, and most of the time we give them whatever they want. But sometimes the public-private partnership is extremely important. And this group, okay, is one of those groups that we need to ensure that they stay in operation, because you can see the cost efficiencies with this public-private partnership. So I just want to let you know, Dr. Sheen, when you present to the legislature, make sure you have for a St. Thomas office also, because as you can see, most of the kidney dialysis patients are actually in the St. Thomas, St. John district. So we need you there, we need you over here, we need you everywhere, and it's very important. We're going to go to Senator Potter. Senator Potter, you're recognized for your 6 minutes.
Thank you very much.
Yeah, the mic for Senator Potter.
Thank you.
Hold the senator's time. Media, the mic for Senator Potter, please.
My time has started. Thank you very much. Thank you very much, Mr. Chair. Good morning, colleagues. Special good morning to Dr. Sheen and the members of the VIDCO team who made a very excellent presentation before us this morning. Mr. Majority Leader, everything in moderation. That's right. Thank you very much. I wanted to ask, just to piggyback off of what the chairman just sort of alluded to, and I wanted to ask Dr. Sheen, is your operation primarily based on the island of St. Croix?
Yes, Senator, it is. And we are in the process of negotiating a lease for the island of St. Thomas.
Okay, excellent. I'm glad to hear that. If your blood glucose level hit the threshold that moves you beyond, I guess, the pre-diabetes level, and you become an unfortunate victim of being diagnosed with diabetes, is that it as far as, is it possible through lifestyle changes for you to move back to a safe state, or are we just basically talking about a maintenance situation right now once you hit that threshold?
I'd like Dr. Nudley Bland to respond to that question, please.
Yes, your question is, if you went from prediabetes and your numbers hit to where we make the diagnosis of diabetes, but you manage it and you improve your diabetes control with your A1C and other factors that we look at as well, your blood pressure and your cholesterol, yes, you can manage it. And I'd like to emphasize, it's not cured, but you have to have continued lifestyle management. Some individuals can come off of many of their medications when they lose weight. They control their blood sugars and so forth. But it's a lifelong management. And so I don't want people to believe that I can go back eating the way I used to, or I don't have to exercise, and I don't have to do the things that actually improved your overall control of your diabetes.
Thank you very much for your response. We've received, and I think all of my colleagues have received, an email from a community activist based on St. Croix, Miss Mary Moorhead. I hope she doesn't mind that I called her name out publicly. And she had a very interesting suggestion that, and I wanted to just get your take on it. Question that she had, is it possible to screen all fourth graders in the public school facilities for indications of diabetes? Of course, it will require parental consent. The thinking is, once we identify those individuals who might be at risk, who may be pre-diabetic, that we will be able to target those individuals and their families more directly to hopefully stave off the further development of this very deadly disease. Is an initiative like that something that, is there value in that? Are we seeing things like that being done in other jurisdictions? Just wanted to get your thoughts on that.
Thank you for that question. I'll respond, and then I'd like Dr. Nudley Bland to share her experiences with this type of work. I do feel that it's very possible. It is something that we would love to partner with the Department of Education on. As she mentioned, it would require the permission of their parents and coordination with the school nurses, etc., as well as we would need to identify special funding to do that, because that would be an expensive undertaking in terms of the testing. But it's very possible. We would love to be able to do that, especially if we can not only screen, but work with the Department of Education to develop interventions for those children that are at risk for diabetes. Dr. Nudley Bland, if you can share anything that you might have been involved in that it might be similar to this.
So I think that is a good endeavor, and a fourth grader is probably around 9 or 10 years of age, and this is the time that we would start screening for diabetes, particularly type 2 diabetes. And so if we can identify those early on and intervene, we can significantly reduce them going on to developing particularly type 2 diabetes. It may not be as effective for type 1. If we do not do anything and that child is not identified as having prediabetes and they continue with weight gain and so forth, in 5 years they will go on to develop type 2 diabetes, which, you know, you think about it in terms of cost that we may have been able to prevent.
Absolutely. I think we have no choice but to embark on an initiative such as that and to identify the resources to make it happen. Are we seeing anything unique on the diabetes front in the Caribbean, in the Virgin Islands, you know, that we're seeing elsewhere? Or is it pretty much the same?
That's a really good question. I feel that our numbers were at 14.9% of our population, and I would imagine that in the other Caribbean islands that is very similar because our demographics is similar, our culture is very similar, and so I'm sure that our eating habits, just being high in starch, is similar as well. So I would imagine that the prevalence of diabetes would be similar in other Caribbean islands as well.
Mr. Chair, if I may just wrap up with one final question.
Yes.
I was just curious regarding just the fact that people of color seem to be suffering more from this deadly disease than others, and whether or not there was studies done on the continent of Africa to look at their diabetes rates on the continent. And are we seeing similar numbers there, you know, compared to Black people or Africans throughout the diaspora?
That's a good question, and in my presentation, I believe I provided specific numbers on what's happening in Africa. The numbers are similar. I'd let Dr. Nuliban provide more context around this.
Yes, there have been studies where they look at the genetics related to those who are at higher risk for diabetes. It's a very complex disease, multifactorial, and so it's really multifactorial. So you have a predisposition, but if your lifestyle actually exacerbates your predisposition, then that increases your chances of developing diabetes.
So maybe more so
If I can also
lifestyle.
add, Senator Potter, to your question as to activity within the region. I spent a number of years working with a large health facility based in Puerto Rico and traversed the English-speaking Caribbean. And to your question, yes, the numbers are very similar. I did work with Sagicor insurance company based in Barbados and conducted a health project with them because it was having the numbers throughout the region in the markets that they serve, it was having a significant impact on their ability to continue to pay the claims at the levels that we see within the region. And also, with regards to study, there is a professor at UWI based in, I think, the Jamaica campus, the medical school there, that has conducted a study with respect to the Afro-Caribbean populations vis-a-vis the African population. Then I think one of the things that he was seeing is that based on changing diets on the African continent and many of the cultures, that you're beginning to see a significant increase in diabetic numbers today that did not previously exist.
Thank you very much for your feedback. Thank you very much, Mr. Chair. I mean, just the wisdom in putting together this very important session, I think there is definitely value in it. Thank you very much.
Yeah, thank you, Senator Potter. You know, just to follow up on that a little bit, You know, we grew up when, you know, we always used to think if the child a little chubby and thing, that mean they're healthy. But of course, you know, the children them before used to be running around and they ain't had no cell phone, they would climb tree and thing. That ain't happening no more. And we received testimony, I think it was from Dr. Bland, that after 6 years old, the children them, the parents them need to watch that. Well, I don't know if we're using BMI or obese, but you know, you could say it's fat, but either way, the child chubby, we're going to use the word chubby. Give us some advice for the parents when the child gets like 6 years old on how to start to control that diet. If we can also hear from the dietitian, Ms. Sumi, on that.
Me?
Yes, Sumi, I didn't hear you. Yes, oh, Dr. Bland, maybe you can, you know, you could jump in since apparently her mic is not working.
Yes, that is a good question and comment. It's so important when that child goes for their well-child checkups, and that they should be weighed, their heights taken, and their body mass index calculated. And as I mentioned before, if your body mass index is above 95th percentile, then you're considered obese. But we really like to intervene when it is greater than the 85th percentile. So how do we intervene? What would I advise my parents? Well, one, eliminate the sugary drinks, and that's one of the easy things that they could take out of the diet. So the juices, and sometimes patients and parents think that juice is healthy, but rather just to eat the fresh fruit. Increase that child's physical activity. So we recommend 60 minutes a day for a child, at least 5 days a week. Limit their TV time, their cell phone time, their computer time, so that they can get that hour of exercise every day. And to monitor their weight. Those are things that can be done. And just some simple things. What I have found, just eliminating just the sugary drinks have helped some families in terms of their children not becoming more obese. And what we generally recommend for children, we don't recommend a weight loss for them, but we recommend that if you could just keep them from gaining, instead of the 5 pounds and 10 pounds they may gain in a year, only gain 1 or 2 pounds so they can grow into their weight. So those are things that I would recommend for parents who is noticing that their child is becoming a chubby or a little heavier, and for their healthcare providers to do the monitoring.
Okay, thank you. Before we go to Senator Carrion, we have a point of information. Senator Gittins, you're recognized.
Thank you, Mr. Chair. Well, you just had your discussion there about whether we reference chubby, BMI, obese, or fat. I thought about the chubbies for real, because being in the store, when you look at it at a certain time a year, a certain time a month, you're seeing these young parents and they're just buying all these sweets, junk, for the children to take in. I wanted to ask Dr. Sheen whether or not VIDCO is partnering with the Department of Human Services and or the Department of Education, again, for the educational piece of this, so that parents and young people could understand the importance of this discussion.
Thank you. That's an excellent question, and we have not reached out to the Department of Education or Human Services as yet. It is on the list of things to do in terms of addressing policy. We've been focusing so much on the services and the education and making sure that those two components of our services are tight and that we're doing a good job. But, policy is really a passion of mine, and you spoke to the Department of Human Services. I think it's so important the Department of Human Services look at their policies for their TANF programs, because I do feel that we, as a territory, could dictate what types of foods that we will allow people to purchase, or provide incentives for them to purchase more healthy foods and snacks for their children. So there is an opportunity for us to partner there. And then where the Department of Education is concerned is what Mary Moorhead mentioned, not only screening children at a very young age for diabetes, but also working with the Department of Education to develop necessary and proper interventions. And so those partnerships are two that are very much heavy on my mind, and something that I will be pursuing in the near future.
Please, please. So hopefully they too are tuned in and reach out to you as well, because I know you have a lot on your plate. But yes, the Department of Health, the Department of Human Services, and the Department of Education. And especially, again, I'm looking at the Department of Human Services through their food stamp program. These parents are buying a bunch of junk, and we need to educate our people. So thank you on that. I'm looking forward to you partnering with those three entities. Thank you, Mr. Chair.
Thank you. And I did want to mention that Dr. Nunli Bland does have a call at 12 o'clock. And so any questions for her? Yes, she's going to be dropping off for another conference call.
Okay. And, just to, re-emphasize the point, right? The president mentioned 184 million for the health insurance. That's what we're paying now. The Medicaid program, 120 million. We received testimony here where just the diabetes patients is 120 million, and then the dialysis patients is 264 million. So this is why, this group here, the VI Diabetes Center of Excellence, is a breath of fresh air. We got to push this public-private sector partnership, because prevention is much more efficient, and of course it saves lives. So, excuse me. So we're going to go to Senator.
Point of information.
Yes, you're recognized, Senator Morris James. Point of information.
Thank you, Mr. Chair. Because the doctor is leaving, I wanted to ask a quick question if I can.
Yes.
Most of us don't like to take the long, difficult road to change behavior. And I know recently and on TV you see a lot of advertisements about Ozempic. And I wanted the doctor to explain the role Ozempic plays in the treatment of diabetes and the reliance on it before she leaves, if possible.
Dr. Nunli Bland, I'm hoping that you're still there, and if you're not, then Carlos Casillo, you should be able to respond to that.
Still.
Carlos, are you there?
Yes. So Ozempic is the new drug. It's not new. It's actually been in the market for a while, but it has gained a lot of attention because it makes you lose weight. Some of the benefits is that it lowers your A1C from like 0.5 to like 1.6%. You lose about 4 to 6% of your actual weight, and it's taken once a week. So in comparison to insulin, which is given, daily or sometimes, with meals, so 3 times a day, this one, it regulates the weight and it regulates your sugar, and it's only once a week. So there is a lot of benefit. Now, when it comes to our patients here in the Virgin Islands, for some reason, they do not like to lose the weight. Some of them say, I'd rather not take the Ozempic because it's going to make me lose weight. A lot of education and a lot of more emphasis emphasis we need to put into, the teaching and the prevention when it comes to the diabetes. We offer also a diabetes self-management class where we explain all the medications. We have the pharmacists go over the medications and everything else. So, in case of the Ozempic itself, it's a glucagon-like peptide antagonist. So basically, it's not like insulin that is secreted by the pancreas. This one is an enzyme that mimics glucagon. Glucagon is the opposite of insulin. So glucagon will be the sugar-like. So the Ozempic will make you lose the weight. It will control your diabetes better. Now, in terms of accessibility to it, only those with insurance will get it, because it costs from $700 to $1,200 per kit. So if you have Medicaid is not going to cover it. If you have a good insurance, Cigna or everything else, for what I have seen in my experience, that's just going to be covered. But that's Ozempic. I mean, it's great for the patients. Unfortunately, not everybody's going to be able to afford it.
Thank you, Carlos.
Yeah. Okay.
Thank you, Mr. Chair. I'll wait for my turn to continue on this subject. Thank you so much.
Okay. Thank you, Senator. Senator Carrion, you're recognized for your 6 minutes.
Thank you, Mr. Chair. Good, it's still morning right now, afternoon now to everyone, my colleagues viewing and listening in the audience, and to Dr. Sheen and her team. Thank you for a very comprehensive testimony this morning, and I want to also commend the chair for having this hearing on a very important topic and much needed for our community. Prevention, I think, is the key, and I think we have a lot of work to do in that area in outreach and education. But I do have some questions, Dr. Sheen, just for some background information on the organization. When was it established?
In October of 2020.
October 2020. Who are the directors of the organization?
In terms of the board of directors?
Yeah, board directors.
Ray Barry is the chairperson. Tatia Monell Hewitt is the treasurer. Janine McFarlane is the secretary. And then we have other members like Dr. George Rosenberg, Mr. Colin Hodge, and Donna Christensen. It's a 7-member board.
7-member board. Thank you for that. Your main funding, where does it come from?
Our main funding comes from the ARPA funds, as well as we have some funds through Health Resources and Services Administration, the USDA. We're getting some funding from UVI. Yes.
Okay. You did mention
and the legislature.
Okay. You did mention in testimony that you do have 4 new grants that I think are coming online.
Those were the ones that I mentioned, yes.
So the 4 new ones is the
USDA, which provides funding. It's a telemedicine grant.
How much is that?
That one is $185,000.
Okay.
And then we have $995,000 from HRSA, which is Health Resources and Services Administration.
Okay.
And that one is going to focus on purchasing our mobile unit, helping to retrofit our office spaces, and purchase some other equipment for the office. And then we also have funding from the legislature.
Okay, that's the 3rd new one.
Right. And then we have some funding coming in from UVI.
Okay, and how much you're getting from this body?
We're getting $200,000 right now.
Good, thank you for sharing that. And then tell me about your the staff. How many doctors do you have?
Oh, wow. So we have Dr. Gail Nunley-Bland, the medical director, Dr. Anthony Oliva, the ophthalmologist, Dr. Liu, and 3 doctors.
3 doctors at the moment. Beautiful. The total staff number in general is how much?
6. And we
6
don't...
excluding the doctors?
Including.
Including doctors,
yes.
Okay. In all, the total is 6?
It's about 6.
Okay, so 3 doctors and
wait, just let me... Yeah.
3 other employees.
Correct. Let me just double check that. I believe it's
more like 9, because we do have a pharmacist as well. In fact, we have 2 pharmacists, one that we've had on board for a while, and then we just signed an MOU with Howard University School of Pharmacy.
Good. So what would you say is your yearly budget?
I would say that our yearly budget is about $1.2 million.
1.2 million.
Yes.
Okay. And I know this here in really, it's about some of the challenges, and we know some of those challenges are maybe financial. So tell us a bit some of those challenges that you're facing.
So right now, I feel that our major challenge is continued funding. That's one. That is why I'll be submitting a request for additional funding to the legislature. The second challenge for us is our location, and we have identified a new location here on St. Croix
That is ADA.
that is ADA compliant.
yeah.
That is a
'Cause
major challenge
Yeah,
for us.
because many of your patients have, they have a health condition.
They do, and especially climbing stairs.
Stairs.
You know, people with diabetes, some tend to have mobility issues, and just that we have right now.
Okay. Financial and the building.
Exactly.
And have you identified, I saw in your testimony mentioned that you have identified new office locations for both St. Croix and St. Thomas?
That's correct.
Okay. And what's your daily average patients that visit your facility?
About 10 to 15 patients
About 10
on
to
a daily.
15.
Yes.
Very well. Are you open to share what the new facilities, new offices locations are? Or you're still in negotiation process?
For the one on St. Thomas, we're still negotiating.
Okay. And so on St. Croix?
On St. Croix, we haven't signed the lease yet. We actually had an architect come from the Army Corps of Engineers to do the rendering, and we'll be developing the scope of work that will go out for bid, and then we'll be able to sign the lease. So even for St. Croix, it's in the Christiansted area, but we haven't actually signed the lease yet, so.
No problem. I understand that. Now, 2023, what was the average number of patients you saw?
For 2023, we saw about 800 patients.
About 800?
Yeah, that we managed the care of.
You managed the care of,
We
okay.
managed the care of
'Cause you also
800
do-
patients, but with the outreach and the patients that we manage, we have about 1,600 patients in
Okay.
our database.
Now, help us understand, it is a nonprofit, but of course, we have different tiers within the nonprofit. You do have a fee scale, so there is some payments. Patients.
So the board has not approved a sliding fee scale as yet. I mentioned the fact that we will be implementing one at some point to assist persons that don't have health insurance.
Okay, so at this time, everything is cost-free for?
Oh, no, not at all.
Okay.
I know when the center first started in 2022, the services were free of charge. But as we bring on additional specialists, there's just no way that we'll be able to provide services for free. So we had to begin billing for services, and the fees for those services, they range based on what the actual service is and the provider that they're seeing.
Mr. Chair, if I may, one last question, I beg your indulgence.
Yes, you may wrap up.
Good. Can you kindly share with us, compared to a regular doctor's office that provides services and fees, what's the difference in that fee scale that would encourage someone to go to your office and receive case management and services than any other office space?
It should not.
Percentage-wise or?
Yeah, there isn't a difference between what we would charge and any other provider, because we're all governed by VI Equicare, and all our providers are credentialed through VI Equicare. So the fees are essentially the same. What I would say that makes us very unique is the fact that we provide not only clinical services, but education services. And I want to mention that the educational portion, the group classes that we have in our center, we have not been charging for those, because we feel that charging even in billing insurance, it provides a barrier for people to come and be educated.
People don't typically want to take the time out of their busy schedule to be educated. So if they find out that they're going to be billed for that, if it's a group class, we do not charge for that. But if it's individual counseling, say for example, the registered dietitian needs to work with a patient one-on-one, then we bill for that. So I think what makes us unique is the fact that we combine the clinical and the diabetes education and intervention in what we do, because we're working towards achieving good health outcomes for our patients.
Along with the outreach.
And
educational-
along with the outreach, because not only are we trying to get the word out about our center, but we're also trying to identify persons that don't know they have diabetes or don't know that their diabetes are out of control. And this is how we prevent a chronic kidney disease. So that's the outreach activities are so critical.
Thank you so much for your testimony and answering my questions today.
Thank you.
Thank you, Mr. Chair.
Yes, thank you, Senator Carrion. Next, we'll go to Senator Donna Fred Gregory. You're recognized for your 6 minutes.
Thank you, Mr. Chair, and good afternoon. Is in order? Okay, good afternoon to my colleagues, the testifiers, and the people of the Virgin Islands. I've been listening to the conversation, and first of all, let me just congratulate my sister, who is a Morgan State University graduate twice. I see Morganites are doing really great things in the Virgin Islands. We just confirmed a Supreme Court judge who is a Morganite. So I'm very proud of that, yes. And now you're before us, and you're twice Morgan, and I'm once Morgan. So, yes.
Thank you.
Absolutely. So let's talk diabetes. And I want to also take this opportunity to congratulate my colleague who actually moved the legislation for the diabetes registry. Because I think it's full time that us as Virgin Islands leaders push the envelope or push the agenda on getting out the campaign on diabetes prevention. We know that we live in a community of Black and brown people, and we know that diabetes in our community, based on the information that you've provided, is the 6th leading cause of death in the U.S. Virgin Islands, and that should concern all of us. I think the data that you provided today is very important data, but my question is around preventative programs. And I know that you are, you're a nonprofit organization, and your focus is some prevention, but basically you're very concerned about taking care of those who are impacted by diabetes. So do you have specific preventative programs that you're working on as a nonprofit? And if I missed it before, I apologize, but I'm very interested in finding out if you have specific nonprofit programs that you're working on, not only within your organization, but extending those arms out to the likes of the Department of Education, and we having those tabletop discussions about how do we push diabetes prevention in our territory.
Thank you so much. So I'll address the prevention piece and the services that we provide in that area. Prevention is a big part of what we do. We conduct monthly diabetes self-management classes on Tuesdays from 4 to 6. So that's monthly. We're getting ready to launch an advanced nutrition class, which will be held on a monthly basis. That would consist of about 4 classes. We will be launching a 12-month program for people with diabetes, pre-diabetes in June, because what they need is very different from somebody that already has diabetes. We're working with them on maintenance in our diabetes class for those that have diabetes, but then those that are pre-diabetes, the goal is to make sure that they don't transition into a full diagnosis. So that's a 12-month program. In addition to that, we've been doing a lot of outreach with the Division of Personnel, doing some educational seminars for all GVI employees. The last one, we had about 100 employees. participate. So we talk about diabetes, what it is, the complications, and how you address, how you manage your diabetes. So that's one. We also provide monthly medication classes that we just had one on March the 12th, and that one was well attended by GVI employees. So we're doing a lot in the education space. I talked about the fact that we are currently designing a summer camp for children that have diabetes. Hope to launch that in June. So we're doing a lot in the prevention space. And then with the partnership with UVI, we're going to be running a mixed media campaign for several months just to educate the community about diabetes, what it is, its complications, how you manage it. But in terms of our work with the Department of Education and say Human Services, we haven't started doing that as yet, but it is a priority of mine because we want to do more work in the schools.
Okay, so thank you for your response. So I would just like to share this. We talk about, do we have data on how many children in the territory that suffers from diabetes? Do we have data on that?
We don't. I know that the Department of Education used to conduct the Youth Risk Behavior Survey.
Okay, so we don't.
Which would give us that kind of information.
Thank you for that. We don't have that.
I haven't seen one.
Okay, so we don't have that information on how many children in the Virgin Islands currently suffer from diabetes. So that's information that I believe that requires collaboration. If we are serious about diabetes prevention, we have to establish what are those buckets that we're focusing on to truly address diabetes in the territory. And that data has to be collected. I don't think it should be difficult for us to collect that data because we have our schools. From your end, I don't know that it is your responsibility, but what I will say is we should engage in discussion with our Virgin Islands Department of Health, as well as our Human Services and our Department of Education to see how we can collect that data so we could share that data. But I will say this. I'm familiar because you talked about the relationship that you're establishing with the University of the Virgin Islands. And my daughter attended Columbia University, and she was a pre-med student at the time. And the University of the Virgin Islands also have pre-med students because we have, can I wrap up?
Time?
They also have pre-med students as they have students that go off to, they have the pre-med program at UVI, but there are programs where universities have where they support young people who are suffering from diabetes to assist them with taking their medication and getting them comfortable and adapting to their situation. So those are the types of discussions that we need to have. I'm not saying specifically your organization, but our Department of Health in particular. They need to be the ones leading the charge with the partnership and then including the nonprofits to support the work around diabetes in the Virgin Islands. So I commend the work that you're doing, but I strongly believe that our Department of Health and our Human Services in particular, as well as the Department of Education, need to come together to begin looking at diabetes in our children, because then it ascends to adulthood, and then we also have to figure out how do we have that campaign around overall diabetes. When they used to have that campaign around littering in the territory, when they had the campaign that says a litter bug's a real humbug. We need to have a similar campaign around diabetes in the Virgin Islands. It's a serious issue, and we are not beating the drum around it enough, and we're not talking about it enough. And this is something that we can't talk about, Mr. Chair, one time. We have to have a deeper dive conversation around diabetes in particular in the Virgin Islands. Thank you, Mr. Chair, for the time. And Dr. Sheen, I look forward to having more conversations with you around this. Thank you, Mr. Chair.
Thank you so much.
Thank you, Senator Fred Gregory. So, Dr. Sheen, I hope you took notes, right? Because that data for the children is very important. So, when you come with the new proposal to the legislature, it would be good if you could reach out to Education, Health, and Human Services so that we can get the data, because, definitely we see the need and how it's helping the community. I had a couple questions here for you. As far as testing, do you do the lab testing in-house to determine? Explain how that helps also the patient care. Does that bring the patient costs down when they present themselves to you? Tell me how you do the lab and how that helps the patients.
So we do lab testing, what we call ClearWave lab testing in the office, but more comprehensive testing, we send them to the local labs for that.
Okay. And so the clinic generates its own source of revenues, right?
Yes, for those types of things, for the visits as well as the lab testing that we do in-house.
Okay. So, and your staff also writes prescription to the patients, et cetera?
Yes, the nurse practitioner does have his license to prescribe.
Okay, so basically, you're like a one-stop shop for the diabetic patients then? They come in there
And that is what we're, correct,
okay.
Senator.
Okay, good.
Sorry.
Well, we're looking forward to you also providing those similar services on the island of St. John, because this is a one-stop place where diabetic patients could go to get the lab testing, the prescription, everything done. Okay, so we're going to go now to Senator Maurice James. Senator James, you're recognized for your 6 minutes.
Thank you, Mr. Chair. Good afternoon, Virgin Islands. Good afternoon, testifiers, especially Dr. Sheen, with whom I worked. And I definitely enjoyed that professional relationship with you. I want to, first of all, let everyone know that April is Autism Month. And so that's another, because we're in this health committee meeting, we need to be aware of that autism exists and that it's a lifelong neurological condition that manifests during early childhood, and more boys than girls actually are likely to be diagnosed. So I just want to make us aware of that within the Virgin Islands, we do have children who are autistic. And as the term autism spectrum, it refers to a range, but focusing on diabetes, which you're here for, I took note of the fact that the doctor said, when I asked the question about Ozempic, that he said that patients don't want to lose weight, which then goes contrary to what needs to be done, whether it's by Ozempic or natural. And I'm a little concerned about that. Is that a cultural thing that happened here in the Virgin Islands?
Yes, I do think that is very much cultural, but I will say that with the physical activity events that we have sponsored, we used to have a personal trainer come into the office to work with patients on an individual basis. That might be true for some patients, but I can tell you it is not true for the majority of the patients, because they recognize, and what we've been successful in doing is showing the correlation between weight gain and their A1Cs.
Okay.
And so I feel that we are getting through with that message, but medications overall, patients do not like to take their medication and they don't adhere. They prefer to use natural remedies.
So culturally, we prefer natural remedies
Yes.
than actually, I understand that.
Yes.
You know, there's a little resistance in all of us.
Yes.
Culturally. One of the other issues, or actually a suggestion that I was going to bring forth that piggybacks on what my colleague talked about, collaborating with education and health. There's also a nonprofit, another nonprofit that I am recommending that you partner with or collaborate in some form and fashion, and that's the Good Food Coalition, because we need to focus on healthy food consumption. And studies have shown that really restricting, for example, SNAP recipients, imposing SNAP restrictions does not stop them from consuming, for example, sugar beverages, sweetened beverages. But by taking them or changing their view and directing them more to healthy food by somehow expanding their budget through incentives. Like, I remember the Good Food Coalition during the agriculture fair had these bonus dollars that you could use to buy produce and food from farmers. Because if we're going to be serious about agriculture in the territory, all these different agencies come together to work to, number one, promote local farming and agriculture, but at the same time, lead our people towards healthy food consumption. I just wanted to recommend that you contact the Good Food Coalition, because there may be some way that the people you treat can also access and get maybe bonus dollars. I don't know. But I remember they used that during the agricultural fair. What about genetic predisposition? How often, I mean, there is a relationship, correct?
Yes, there's definitely a relationship, and sometime in the future, because a part of our mission is research as well. And so our goal at some point later on is to really focus on genetic testing. And so in partnership with Johns Hopkins University. So that is something that we see in the near future as well.
Okay, that's good to know, because I would imagine that then I would want to be screened more, just like any other disease or any other illness, for example, cancer, breast cancer. If you know that your family has had breast cancer, they usually say to you, then you should be screened more often than someone who doesn't have a family history, correct?
That's true.
Yeah. What's the mortality rate? I know you have here, it's the sixth leading cause of death. What is the mortality rate?
I would have to get that information to you because I don't have that specific data in terms of the mortality rate. We would have to get that from the Department of Health.
My colleague here and I was trying to figure out what were the other 5 before. Do you, just out of curiosity, do you know the 5 that are above the diabetes?
Well, the one that's above diabetes is heart disease. That's for sure. And then cancer would be among the top 5. Homicides would be among the top 5 as well.
Homicides?
Yes.
Yeah. Mr. Chair, I believe my time has been called, so I'll adhere to that.
Oh, okay.
Thank you very much.
Okay. When you look at those leading causes of death, in the fact that diabetes contributes to stroke, it also contributes to cancer and, all those things. Diabetes could be an indirect cause of a lot of those that are even above it, like the heart and the cancer. I'm going to tell you a true story. Last year I had my BMI tested, right? And I was at 28. I remember the number good. 28 was, it was high. I don't remember where it is. I know Dr. Bland left. But and I was 215 pounds, so the whole last year I've been, losing weight. I weighed myself the other day and I now 216. So I did a whole year trying to lose weight and I actually gained a pound. So we ain't doing too good. So I can understand it with the community. It's not easy to lose the weight, we like to slux down for real in our community, and Carnival coming up, it's impossible to lose weight in Carnival. So it's something that you really have to work on to lose weight. It's not easy. Colleagues, we're going to go for a burning question. We'll allow a burning question. Senator Novell Francis, you're recognized.
Thank you very much, Mr. Chair. Again, I want to thank VIDCO for the work that they continue to do in this community. And I think it's a very important component. Dr. Sheen, I just wanted to ask you in regards to your effort to continue your education and prevention. I know that you spoke about getting the mobile services out and meeting people where they're at. I think that's an excellent idea, and we look forward to that. But in terms of public education, are you also having discussion with WTJX, the movie theater, post office, Ledge VI, those entities that continue to bring these information readily available to the individuals within this crisis that we're experiencing?
I'm so glad you asked that question. Yes, we have had conversation with WTJX about doing several series on diabetes, something that we need to follow up on. We are in talks now with UVI. They're providing some funding so that we could do sort of a mass media campaign to educate people about diabetes. And those PSAs that we will be developing with the funds we're receiving, those will be played in the movie theaters, etc. We're also really crafting a comprehensive marketing campaign for how we get the word out. We've started with the Department of Personnel in meeting with GVI employees. We've been sending out a lot of our promotional materials to all government employees and doing it that way. We need to include the legislature in that as well. So we are having those conversations.
Very well. And in terms of partnership, have you had a conversation with Cigna, United, or any of those other insurance entities in terms of how, too, they can assist in this endeavor about public education and prevention?
We have had extensive conversation with United Healthcare and their leadership, hence why we participated in an outreach event with them last year. Cigna is really next for us to have that conversation, but I did speak with the chairperson of the Government Employees Board, and so we are going to be scheduling a presentation for Cigna and that group in the near future.
Very well. Thank you very much, Mr. Chair, for the time and opportunity. And again, congratulations to you and bringing forth this very, very important discussion here today. Thank you.
Thank you.
Thank you, Mr. President. Any burning questions? Yes, Senator Potter, you're recognized.
Thank you, Mr. Chair. My final question to Dr. Sheen is regarding diabetes research. And I know we sort of spoke around it here today. Are we doing enough in this regard on the local front regarding diabetes, just diabetes research? And what role, if any, do you think your organization can play in collaborating with local public health officials to ensure that we step up our game as a territory regarding just research in diabetes?
Glad you raised that question. So the Virgin Islands overall is an understudied population. And so research is so important to better understanding this condition. Why is the prevalence so high in the Virgin Islands? We assume it's because of our eating habits, but really is it? So I am a big believer in research. I conducted original research in the Virgin Islands, looking at the barriers associated with uncontrolled diabetes among health center patients. And we are going to be partnering with, whether it's the Department of Health or academic institutions, whether at Howard University and at Johns Hopkins, to do more research in this field so that we could better intervene in addressing this issue in the Virgin Islands.
Thank you very much. Thanks, Dr. Sheen. Thank you very much, Mr. Chair, for the time.
Thank you, Senator Potter. I just wanted to close with this one thought, right? The 35th legislature, we just passed Bill number 350207 to create the Territorial Chronic Kidney Disease, Diabetes, and Stroke Registry. How would that registry help you? Can it give you more access to federal dollars And how can you also contribute to having an accurate registry?
Well, as I mentioned before, that we are also embarking upon launching a facilities-based diabetes registry. We plan to launch that in May. And so it's going to help tremendously, because the difference between what we're doing and what the Department of Health will be doing is that they're launching a population-based registry that will collect information on diabetes and chronic kidney disease for the entire territory. So once we launch our registry, our information will be connected and flow into their population-based registry. So I could see the two working together quite nicely.
Thank you, thank you. And I think we've exhausted of our questions. So at this time, Dr. Julia Sheen will allow you a 30-second close.
I just wanted to thank you so much, Senator Fonseca, for inviting me to give testimony on the Virgin Islands Diabetes Center of Excellence and to share more about our services, but also to educate the community about diabetes and the burden of diabetes globally, nationally, and here in the Virgin Islands. I thank you all. Your questions were on point. I'll take back your recommendations and make sure to implement it. And I thank you so much for supporting the Virgin Islands Diabetes Center of Excellence. And I wanted to remind the listening and viewing audience of where we're located here on St. Croix at 4040 La Grande Princess. We're right across the street from the James Memorial Funeral Home on the second floor. We'll be moving from that location at some point, but that's where we are. And to reach us, the number is 340-208-0260. Once again, that number is 340-208-0260. And I brought some gifts for the senators, just a bag with educational materials. And for those of you on St. Thomas, I will make sure that you receive your bags as well. Thank you to you, senators of the 35th Legislature, and to the Virgin Islands community for having me.
Thank you very much, Dr. Sheen, and once again, we're so happy for the information that you've provided to us. The Committee on Health, Hospitals, and Human Services will stand in recess for 15 minutes.
Thank you.
the Committee on Health, Hospitals, and Human Services is out of recess. In Block 1, we received testimony from the Virgin Islands Diabetes Center of Excellence. Dr. Julia Sheen gave testimony. And, you know, we got the real numbers. We know that there's over 12,000 people in the Virgin Islands that's living with diabetes. You know, 50% of them are obese. We also, you know, discuss some numbers. You know, it's about $120 million the community is spending just to treat the diabetic patients. It's about $260 million the community is spending to treat the kidney dialysis patients. And of course, you know, the government pays $184 million for the Cigna insurance. In addition, the Medicaid program is another $120 million. So obviously, diabetic illness in this community is very expensive. And it was so enlightening to learn out that this is a private group. Public sector cooperation is what we need here. And we're only giving them $200,000. So you see how more efficient it can be when we bring some partners to help with the government. I'd like to also announce that this week is Public Health Week, and tomorrow, Thursday, April 5th, the Department of Health is going to have some community engagement activities in St. Croix from 9 a.m. to 2 p.m. in Dial to Rent parking lot, and St. Thomas, 9 a.m. to 2 p.m. at the Snyder Hospital, St. John from 9 a.m. to 2 p.m. at the Castro Clinic. Friday, April 5th, the Department of Health is going to have a scavenger hunt from 8 a.m. to 12 p.m. Saturday, April 6th, they're going to have a family fun day at Megan's Bay, and also a family fun day at Kramer's Park in St. Croix. Madam Chair, can you read Block 2 and Block 3 into the record? Madam Clerk.
Block 2, the committee will receive testimony on the operational status of the Wang F. Louis Hospital. Invited testifier, Dr. Doug Cook, Chief Executive Officer, Wang F. Louis Hospital. Block 3, the committee will receive an update on the transition of the Wang F. Louis Hospital to the JFL North facility. In addition, the members will receive testimony on the construction and development of the Charlotte Kimmelman's Cancer Center and Maya Keating Smith Community Health Center. Invited testifier, Mr. Darrell Smalls, Executive Director, Facilities and Corporate Development, Territorial Hospital Redevelopment Team. End of reading.
Thank you, Madam Clerk. We want to do a mic check, make sure that the mics are working. You could just state your name and your position. We'll start with you, Mr. Cook.
Good afternoon, Doug Cook, CEO of Governor Wang F. Louis Hospital.
Darrell, yeah.
Good afternoon, Darrell Smalls, Executive Director, Territorial Hospital Redevelopment Team.
Good afternoon, Doris Plaskett, Chief Nursing Officer.
Good afternoon, Chris Lewis, Senior Vice President of Finance.
Okay, thank you very much. Well, we're all ready, so we will allow you to proceed. We'll start with you, Doug, and then we'll go with Darrell, and then we'll have the senators join in on the questions. What we'll do is we'll merge Block 2 and Block 3, because, you know, in some instances they are related, being the Wang Louis Hospital. Darrell, you're in charge of the renovations for both. So, Mr. Cook, you can proceed with your testimony.
Certainly, Senator. And before I begin, I do want to acknowledge that we do have JFL executive team members on St. Croix as well.
Okay, on St. Croix, can we do a mic check to make sure that all the mics are working?
Good afternoon, Mavis Matthew.
Good afternoon, Patricia Canagata.
Good afternoon, James Rollins.
Okay, thank you very much. Mr. Cook, you can proceed with your testimony.
Thank you. Good afternoon, Honorable Senator Ray Fonseca, Chairman of the Committee of Health, Hospitals, and Human Services, honorable committee members, other senators of the 35th Legislature of the U.S. Virgin Islands present, and the listening and viewing audience. I am Douglas Cook, a fellow of the American College of Healthcare Executives and Chief Executive Officer of Governor Juan F. Louis Hospital and Medical Center. I appreciate the opportunity to be here with you this afternoon to discuss the operational status of JFL. To assist with the presentation today is the Senior Vice President of Financial Services, Christopher Lewis, Chief Operating Officer Hazel Filbert, who is currently not present, Acting Chief Medical Officer Dr. Mavis Matthew, Chief Nursing Officer Doris Plaskett, Chief Human Resources Patricia Canagata, Chief Legal Counsel Patricia Welcome, who is also not currently present, Chief of Staff James Rollins, and of course Daryl Smalls. Before I delve into the focus of this testimony, I would like to take a moment to express my heartfelt appreciation towards the staff of JFL. I understand that our team members are the backbone of our organization and our #1 priority. I am deeply grateful for the opportunity to work alongside such dedicated and resilient individuals. Thank you for all your exceptional work and unwavering commitment to the betterment of our organization. We are proud of the fact that we have been operating within JFL North for almost a year. We have a focus on stabilizing operations and growing our workforce, process improvement, and expanding our care model. Today's testimony will cover an overview of JFL's human resources, operations, and finance, along with updates on growth and community engagement. People. The backbone of any healthcare system is the people, the caregivers, and the support staff who are directly responsible for the patient outcomes and satisfaction levels. At JFL, we place our highest priority on people, and we are proud of our human resources team for attracting and retaining employees. Despite the industry's labor shortage, we have successfully filled 60 positions in FY24. We are particularly excited about the strategic hiring of our Director of Security, which has enabled us to fully staff our security department, as well as our Director of Risk Management and Guest Services Manager, just to name a few. In addition, the Graduate Nurse Program was reestablished in collaboration with the University of the Virgin Islands School of Nursing and with support from the Benny and Martha Benjamin Foundation. It is a highly effective career development and training program that enables new graduate registered nurses to transition seamlessly into the clinical practice. So far, we've hired 10 of 14 graduate nurses in 2022 and 8 of them in 2023. These nurses successfully cleared their NCLEX RN examinations and were onboarded as full-time registered nurses at JFL, fully equipped to provide excellent care to our patients. We are also reestablishing the Student Nurse Extern Program this summer for 5 juniors and 5 seniors enrolled in UVI's School of Nursing. The Student Nurse Extern Program also provides support for student nurses with clinical experience and studies for the NCLEX exam. This will also promote confidence in JFL as a future employer. With significant improvement in recruitment strategies, we are also prioritizing employee retention through engagement, communications, and career development. To achieve this, we hired a hospital staff educator, reinstated the Hospital Employee Engagement Committee. We also believe it is critical to provide employees with the opportunity for advancement and promotion within the organization. We have several examples of this, including key positions such as Recruitment and Retention Officer and Public Information Officer. Our commitment to our employees and their professional growth is unwavering, and we will continue to work tirelessly to foster a positive and supportive workplace culture. We continue to tackle one of the biggest challenges, managing the increase in salary demands to ensure that the salaries are at par with national standards. We are proud to announce that we have completed the negotiations of the collective bargaining agreements with the licensed practical nurses and the Virgin Islands Nurses Association. We have completed the negotiation phase for the Registered Nurse Leadership Union, and we are confident that we will reach a successful agreement. We believe that these negotiations will not only help us decrease employee turnover rates, but also make JFL an even more attractive employer. The biggest challenge remains staff burnout and recruiting and retaining medical professionals, particularly in clinically specialized areas such as the allied health. The data for healthcare professional shortages areas highlights the rural states and remote territories will experience the highest shortages of medical professionals per capita, making it twice as hard to meet our staffing needs. Likewise, JFL is faced with a slow but steady attrition of physicians over the years. While some specialties have been successful at recruiting MDs to join the staff, such as OBGYN and neurology, there are other specialties still staffed with single providers such as urology, general surgery, psychology, gastroenterology, pediatrics, internal medicine, and ENT. To offset this shortage, locum tenens physicians have been utilized to supplement the physician workforce. The need for subspecialty care will increase as we address the aging of the population in the territory as elsewhere. With a full-time physician recruiter, the focus is on acquiring the HISPA designation, recruiting physicians through the J-1 visa program, augmenting relationships with residency programs, and claiming VI-raised physicians. Despite all the efforts we continue to make, we recognize that in certain areas we still have unmet needs. Several of these are currently in the Allied Health Division. These shortages cause current employees to work additional shifts and longer hours. I personally want to say thank you for their efforts, as they do not go unnoticed. We will continue to take assertive measures to improve our recruitment and retention strategies to overcome the challenges and meet our staffing needs. Quality and service. JFL North provides comprehensive services to its patients with 52 beds, 16 emergency room beds, 2 trauma beds, 4 behavioral health observation beds, and 4 operating rooms. These clinical areas are supported by a variety of departments, including nutrition services, housekeeping, laundry, laboratory, and pharmacy, just to name a few others. The Quality and Performance Improvement Department ensures that patients receive high-quality care and makes necessary improvement to enhance the facility's performance. JFL Maine is certified by the Centers of Medicare and Medicaid Services, which regularly evaluates the facility to ensure it meets the Medicare conditions of participation for all services and areas. Our JFL North Hospital operations recently underwent its first full CMS hospital survey from December 11th through the 16th. This was followed by a second CMS life safety survey from January 29th to February 2nd. The surveys consist of observations and walkthroughs of the facility, clinical and ancillary departments, as well as a review of policies, documentation, employee files to assess compliance. JFL has not received the official survey reports from CMS. However, work is in progress to address the areas identified as opportunities for improvement. JFL also maintains accreditation from the Joint Commission for the Laboratory Program, the Nuclear Regulatory Commission, the American College of Radiology, and the Food and Drug Administration. These programs support patient care in radiology, imaging, and laboratory testing. We remain committed to the continuous improvement of operations and services to ensure the high delivery of high-quality care and safety for our patients, while also focusing on patient experience. We have established a patient experience department comprised of patient experience specialists, previously known as patient advocates, and have partnered with the Barrel Institute, which provides training to staff on core concepts related to patient experience. Patient satisfaction is part of the patient experience measured by surveying patients post-discharge. This survey data helps us identify our strengths and weaknesses and assist in the implementation of improvement plans. This will enhance our overall patient experience in the future. It also compares our scores against the national averages and establishes benchmarks. Our operations are faced with a few challenges, including the emergency room department wait times and the housing of boarders. JFL continues to struggle with the problem of boarder patients who no longer need acute hospitalization but cannot be discharged due to limited services such as long-term care beds, assisted living facilities, and home health care in the territory. Our case management department continues to work closely with the Department of Human Services and other transitional care home assistance services to place the patients in the appropriate care facilities. Our goal is to reduce the length of hospital stays for our patients who do not need acute care and to ensure that their discharge is in a timely manner. Thanks to the collaboration of various agencies and the individuals, we have managed to lower the number of boarders from more than 10 to just 4. This challenge directly impacts the emergency room department wait times, creating a domino effect. At JFL, we see an average of about 40 patients daily in the ED. In the first quarter of 2024, we noticed an increase in the number of Level 4 and Level 5 ED visits compared to the same months of 2023. Level 4 and Level 5 visits are for primary care and non-emergency complaints. Emergency department wait times are complex, hospital-wide issues that is impacted by resources such as staffing levels, treatment rooms and bed capacity, radiology and laboratory turnaround times, etc. Based on feasibility and availability of resources, the fast track space is activated whenever there is an influx of patients with no available beds in the ED. It is important to note that increased wait times are reflective of non-life-threatening complaints, as all patients undergo triage upon arrival. Those with life-threatening emergencies are immediately treated in exam rooms. To address the issues, JFL has maintained a multidisciplinary team known as the Emergency Room Department Improvement Team. It oversees the quality improvement efforts aimed to reduce the wait times in the ED. Finance. JFL's operating revenue is broken down into gross billed, net collections, and cash collections. Cash collections is further broken down into the collection percentages as evidenced in Exhibit 4. In FY24, commercial payers accounted for 46% of the collections, representing a 28% increase. However, Medicaid decreased from 27% in FY23 to 13% in FY24, representing a 52% decrease in our cash collections, even though we only seen a 3% decrease in our Medicaid discharges. Medicare has demonstrated an 18% increase in payments from 33% in FY23 to 39% in FY24, despite the same amount of discharges year over year. For FY24 year-to-date, JFL has accumulated 77% uncompensated care for discharges and 81% uncompensated care for outpatients. In this case, uncompensated care includes only Medicare, Medicaid, and self-pay patients who made up less than half, which is 45% in FY24, of the collection of JFL's collection percentage. In addition to uncompensated care, we are also challenged with the rising cost of health care. We saw an increase in clinical staffing agencies and locum expenses. Recruitment and retention of healthcare providers are key to stabilizing the operational cost of care and enhancing revenue generation. Currently, we are projecting a total expense of $16.3 million. Staffing agencies were originally financed through the COVID-19 grant through the Department of Health. However, it is now being financed slowly by JFL. This is why we need to continue our focused efforts on recruitment and retention. We continue to lessen our reliance on staffing agencies demonstrated in Exhibit 7, with only 20 agency staff employees compared to 58 previously. The lack of reimbursement and increasing cost places JFL in a cash flow deficit. We have fine-tuned our billing collections process to bring in more cash, yielding an increase in operating cash receipts from $17.8 million in FY23 to $19.6 million in FY24, despite not receiving Medicaid reimbursement. We are actively working with MAP to identify the source and resolve this challenge. Growth. With the outlined cash flow deficit, JFL also recognizes the need to augment revenue to stabilize our systems, which are key to delivering quality patient care for the people of St. Croix. Our focus on improving efficiency and quality will help us increase our overall volume of patients throughout the facility. We also recognize the need to restore some of the revenue-generating outpatient services for which we were once the sole provider and at least reclaim a percentage of that market. We must reestablish the Virgin Islands Cardiac Center. This program provides much-needed services here in our community. Since we have successfully moved patients out to JFL North, we have begun the necessary work. The cardiac catheterization lab has been out of service for many years. We are evaluating multiple vendors that may be able to bring the system back online. We have also applied for a grant that, if awarded, may serve as a funding source to replace the unit completely if necessary. This is just the beginning of a multi-phase approach that is underway to find the necessary interventional cardiologist and support team. We are also working to expand our outpatient clinic with the goal of being open 5 days a week and providing follow-up care to our patients. The Little Grand Princess Dialysis Center will be completed, and we'll be moving our dialysis patients from the trailers to the hardened and safe structure. We have reestablished our foundation and have already used their support to apply for over $5 million in grant funding to assist our efforts. Community. With a strong focus on patient experience, the exceptional work being provided by our caregivers, the results of the patient satisfaction data reflects that our inpatients are overall satisfied with the services being provided in all of the key driver areas on the HCAHPS survey. However, the data also shows the same patients giving our institution an overall lower rating. Based on this data, we continue to prioritize community engagement, intending to rebuild trust in the people of St. Croix. This strategy involves community service and events, media presence and engagement, and community partnerships. JFL maintains a partnership with the Martha and Benny Benjamin Foundation Incorporated and the UBI School of Nursing to invest in our local student nurses' training and clinical experience. Recently, we have partnered with the Make-A-Wish to grant and fulfill life-changing wishes to critically ill children in the community. To date, we have successfully referred 2 patients who are receiving their life-changing wish. We now offer a variety of programs under Guest Services Department. The volunteer program has been reinstated with 17 student volunteers, 4 student interns from the St. Croix Career and Technical Education Center, 2 senior volunteers, 2 members from the Senior Community Service Employment Program, 1 volunteer therapeutic musician, and 2 receiving training on day-to-day basis routines from Island Therapy. Volunteers are placed throughout the hospital, offering career exploration for students and allowing others to give back to the community. JFL's chaplaincy program has also been reinstated with 3 active chaplains offering spiritual care services on the medical units multiple times per week. Through this program, we hosted JFL's first student convention, which was a tremendous success, with 65 registered students and 5 high schools. Students had the opportunity to interact with the healthcare professionals, explore healthcare careers through hands-on activities, and tour JFL Hospital. We continue to emphasize the use of the JFL website, radio and digital ads, and social media for community engagement. Through these channels, we are dedicated to rebuilding the trust in the community. In closing, As always, the JFL executive team thanks Honorable Senator Ray Fonseca, Chairman of Committee on Health, Hospitals, and Human Services, and all the committee members for granting us the opportunity to provide this testimony today. A special thank you to the Honorable Governor Albert Bryan Jr. and his team for all the support, and to our Board of Directors for their commitment to our hospitals and ongoing dedication. Finally, to the community of St. Croix, thank you for the overwhelming support, grace, and love you have shown for JFL. We stand by and welcome to answer any questions you may have. Thank you.
Thank you, Director Doug Cook. Okay, we will proceed to Darrell Smalls. You may proceed.
Good afternoon, Honorable Senator Ray Fonseca, Chairman of the Committee on Health, Hospitals, and Human Services, Honorable Senators of the Committee on Health, Hospitals, and Human Services, other Honorable Senators of the 35th Legislature, Senate staff, fellow hospital testifiers, and the listening and viewing audience. My name is Darrell A. Smalls, Executive Director of Facilities and Capital Development for the Territorial Hospital Redevelopment Team, otherwise we call THRT, which I serve under the leadership of Chairman Christopher E. Finch of the Virgin Islands Government Hospital and Health Facilities Corporation. Thank you for this opportunity to testify today before the Committee on Health, Hospitals, and Human Services with respect to the recovery efforts as it pertains specifically to the transition of the Governor Juan F. Louis Hospital to JFL North facility, as well as the construction and development of the Charlotte Kimmelman Cancer Center and the Myra Keating Smith Community Health Center on St. John. As the Executive Director of the THRT, my primary role is to manage and oversee the planning, programmatic design, final design, bidding, project management, construction, procurement, and closeout for the redevelopment of our territorial health facilities to include the Juan F. Louis Hospital, the Roy L. Schneider Hospital, the Charlotte Kimmelman Cancer Institute, and the Myra Keating Smith Community Health Center. As you heard in the previous testimony this afternoon by Mr. Doug Cook, Chief Executive Officer of JFL, patients and all inpatient services successfully transitioned on April 25th, 2023 from JFL H into what is now known as JFL North. Despite the Herculean undertaking, the transition was seamless due to the collaborative effort of the entire staff of JFL, the THRT, and the many community partners. During my last testimony before this committee, I reported on several milestones that remained. I am pleased to report today that the construction of the critical administration building has been successfully completed and staff will soon transition into this new facility no later than the end of April 2024. This facility will serve as the primary entrance to JFL North and will provide connectivity between JFL North and the Virgin Islands Cardiac Center. At 6,500 square feet or 6,500 square feet, this two-story temporary structure includes 2 elevators, provides working spaces for physicians, nursing, and support staff who must be present 24/7. In addition, I'll allow you to see a couple more slides of the interior of the critical admin building. In addition, a site located on Hess Road has been leased that will provide space for all remaining non-clinical functions that must be transitioned out of JFLH. These functions include dietary storage, medical records, business office, finance, materials management, and the executive staff of JFL. The administrative functions will be housed in a 15,000 square foot 2-story structure along with a warehouse of more than 5,000 square feet. This location is slated to be move-in ready no later than the end of June 2024. The development and construction of the 5-acre leased lot to the east of JFL North is another undertaking that is essential for the demolition of JFLH to proceed. Once developed, this site will provide parking for staff and visitors, a critically needed building to provide on-site storage for food and medical supplies, medical record storage, and support services for facilities maintenance. At present, these services will remain within JFL until these structures can be developed. Bids to develop the 5-acre lot were received on Wednesday, March 27, 2024. These bids will be evaluated to determine the one that is deemed to be responsive, is cost reasonable, and has met all the requirements as set forth in the solicitation. Once that determination is made, a notice of award will be issued. The development of this lot is vitally important to the day-to-day operations of JFL North, as this site will address the critical challenges we now face. As I transition to the St. Thomas-St. John District, I am happy to report that the long-awaited reconstruction of the Charlotte Kimmelman Cancer Institute has finally commenced. The groundbreaking ceremony for CKCI was held on November 4th, 2023. THRT officially issued the notice to proceed to J. Benton Construction, LLC on March 2nd, 2024, with an effective start date of March 4th, 2024. This project is slated to be completed by September 3rd, 2025. The total contracted construction cost is $29,180,045.21. In addition to the construction of this facility, I am pleased to report that FEMA awarded $5,561,063.53 with a 98% federal cost share of $5,449,842.26 for the replacement of major medical equipment that was destroyed in the hurricanes, to include the linear accelerator and the CT simulator. While we did in fact receive this notification on April 1st, it was definitely not an April Fool's joke. As it relates to CKCI's progress, J. Benton Construction has completed the enabling work to ensure a safe construction zone and perimeter around the center. This includes the installation of a 6-foot silt fence, completion of site logistics plan, and the setup of office trailers. Phase 1 is completely ensuring that CKCI is an isolated, standalone structure. This means that all connections to and from Roy L. Schneider Hospital will be demolished. This includes the demolition of existing shear walls on the CKCI side, demolition of all utilities and plumbing, and the removal of the shared stairwell in doctor's parking. Phase 2 of the project is preparation for the layout and installation of the new structural columns and beams for additional offices. This will be followed by Phase 3, which is the demolition and installation of the utility yard foundation. This area will serve as a new location for all mechanical equipment and standalone water tanks that will supply CKCI. The vegetation, soil, and any other decaying material will be excavated to the necessary grade to create the foundation footing for the slab. The Myra Keating Smith Community Health Center, which was also severely impacted, has received a fixed cost offer from FEMA in the amount of $37,302,222.54. The reconstruction effort of MKS is currently included with the St. John Vertical Bundle as part of the Office of Disaster Recovery's Territorial Reconstruction Initiative, which is projected to be solicited by the third quarter of 2024. THRT, FEMA, and the Office of Disaster Recovery have remained and will continue to remain vigilant and steadfast throughout the redevelopment of our facilities across the territory. Similarly, THRT, along with the Territorial Board and the executive leadership teams of both JFLH and SRMC, continue to work collaboratively to address all issues that may arise, especially with respect to the medical and clinical programming efforts of these 4 facilities. As with any construction-related projects, we have encountered numerous roadblocks. However, we face each challenge with the mission to make the best decision with the information we have at the given time to ensure that we are constructing the most efficient, standardized, resilient, sustainable, state-of-the-art healthcare facilities for the people of the Virgin Islands. Our residents deserve no less. As I conclude my presentation, I must personally thank Ms. Kristen A. Hodge, Recovery Director, the local joint JRO USVI FEMA office for her continued support of our hospitals, and Mrs. Adrienne Williams Octolin of the Office of Disaster Recovery for her unwavering support as a liaison between the hospitals and FEMA. Equally important, I want to give thanks to the Territorial Board, the executive leadership teams of both facilities across districts for their support to the Territorial Hospital Redevelopment Team and to the consummate professionals of the THRT team. This concludes my presentation. I will remain available to answer questions you may have at the appropriate time.
Thank you, Mr. Smalls, and also thanks to Doug Cook. Okay, couple questions. Smalls, I wanted to start with you real quickly. With the 98% match, right? Federal cost share. The other 2%, that other 2% comes from where?
Good afternoon, Senator. The 2% originally, as we understood it, was part of the CDBG program through Virgin Islands Housing Finance Authority, and that's where that 2% will come from.
So, because last year the legislature approved a line of credit to the administration. Most of it was from WAPA, but a percentage of it was supposed to go to advancing projects. Has that helped your efforts? Are you beneficiary of that?
Indirectly, we're all a beneficiary. I believe that the entities who have received that funds were those that were in the queue before our projects came online. Right now, my team continues to work daily with VIHFA to provide all the necessary information to be able to facilitate that match. One of the challenges that we do face today is because of the change from the 90-10 to the 98-2, a lot of the documentation and invoicing that we previously supplied, now that is being amended.
The reason why I asked that question, right, is you single-handedly, with those 4 projects, the Charlotte Kindelman Cancer Institute, Wang Louis Replacement, Roy Snyder, and the Myron Keaton. There's no other single person in the government that is responsible for more federal dollars than yourself. I'm not going to give the numbers because I know the contractors been using those numbers that we put out to raise the bid, and when they go out to bid, you don't have enough money. But it's a whole lot. So I'm glad to hear that indirectly you're benefiting from that.
If I may, Senator, I'm glad that you raised that point because every opportunity I get, I like to make it, and especially public, to all the contractors. Yes, you're fully aware of what the federal funds that have been appropriated, but those funds are not solely for the construction efforts. There's a lot of underlying costs that are associated with that dollar figure. So that's why we encourage all of our contractors to really sharpen their pencils because we still have a lot of work that needs to be completed with those dollars that have been allocated by FEMA.
Okay, good. Real quickly, we're going to go to a round of 8 minutes questioning for the senators, but the Charlotte Kindelman Cancer Center, I'm glad to see that you now have the money. You said that April 1, now you have the money for the equipment. So that means what is not going to be replaced brand new? It's going to be all new equipment now in this Charlotte Kindelman Cancer Center?
That is where we're headed to, Senator. All new equipment, a brand new linear accelerator, which provides the radiation treatment, as well as the CT simulator, which is associated piece of equipment for the whole entire radiation treatment. We just completed all the solicitations for all of the medical equipment that will be utilized within the facility as well.
Okay. I'm not an expert on this, but I know in cancer you have surgery, you get the radiation, and you get the chemotherapy. Are you also going to be providing the chemotherapy in the Charlotte Kindelman?
Absolutely. Part of the building expansion includes additional bays so that the SRMC can provide additional patient infusion treatments.
Okay, that's good to know. Doug, I want to go to you real quickly. So I don't know if you have this or if, Mr. Smalls will have this. But right now with the Wang Louis North, you have 52 inpatient beds. What will the new Wang Louis final construction, the new building, the new hospital, what would be the inpatient beds counts in that one?
Yes, sir. Thank you, Senator. We are expecting and designing the new replacement hospital of Juan F. Louis Hospital to be at 118 beds.
Okay, and you have 4 operating rooms. Currently, how many operating rooms you'll have in the new final one?
The new hospital, the replacement hospital, it gets a little complicated when we define those rooms because there's going to be 2 cath labs. There's also procedure rooms, but it should go up to, I believe, 6 operating rooms.
Okay. So, Doug, let me ask you, because I'm a little concerned, right, when you mentioned that 77% uncompensated care for your discharges and 81% for the outpatients. Those are astronomically high numbers. What is the hospital doing to assist the collections? Because, the patient presents, you take the information down, and why are those numbers so high? They just don't have the ability to pay, or what is the problem?
You want me to start? Yeah, I'll start to answer that question, Senator, and I may turn it over to Chris. But from just a sphere operational perspective, it's largely because if you look at the percentage of our business is largely Medicaid and Medicare and no pay.
Okay, I see Medicaid is 52%.
So the less commercial business that we have, we will see a higher amount of uncompensated care. I'll turn it over to Chris Lewis, and he can tell you exactly what we're doing to improve those numbers.
Okay, before we go to Chris, I wanted to follow up on the Medicaid, because I know you mentioned that you were meeting with them and they were, you're working out something, and I know we had an emergency meeting last month, and, you had a problem with the Medicaid. Have you received your Medicaid for January, February, March? Where are you with the Medicaid payments now?
We haven't received a full Medicaid payment since November. We've been working with the MAP office as far as trying to figure out where the disconnect is. My understanding is that it's an issue with a technological issue between Gaineswell and themselves, and they're working on fixing that. And we've been told that it would be done no later than the middle of April.
So cash flow wise, then how are you keeping the doors open? You must not be paying some bills then. What's
Correct. We've had to hold back on a lot of our payables. We've also, encouraged our team where it's lowered our collection rates, but we've been submitting bills to the payers without having all the documentation completed so that we can get paid and then resubmit it once we get the rest of it pushed through as well.
Okay, so since you mentioned documentation, is Medicaid office saying that they need additional documentation, or you haven't provided a proper documentation to be paid? Is that the reason, or is that part of the reason, or is it just because they're slow in paying you?
I don't believe it's either of those reasons. I believe it's a technical issue between Gaineswell and their department, which I can't speak on.
So what's the total outstanding Medicaid payments owed to Wang Louis?
So when I pull my entire roster from what's still pending in our Medicaid balance, from inpatient and outpatient, I'm showing roughly about $7 million.
Okay, we're going to go to a round of 8 minutes. We're going to start with Senator Marvin Blyden. Senator Blyden, you're recognized for your 8 minutes.
Thank you so much, Mr. Chair. Good afternoon to you, E.D. Smalls and CEO Cook, and thank you so much for your testimony the testimonies. CEO Cook, you spoke in reference to the move to JFL North. It's been almost a year. And you spoke in reference to stabilizing operations, growing out your workforce, improvement in processes, and extending out your care model, right? But let me ask you, because despite that, you said you have successfully filled 60 positions during fiscal year 24. And you also hired 10 or 14 graduates from the nursing program in 22, which is very good. I'm happy to see that. And you have also hired 5 juniors and 5 seniors enrolled in UVA School of Nursing. But at the same time, you have done all that and you still have staff burnout. And you have been challenges with recruiting and retaining our medical professionals. So it's a lot going on at the same time. You also spoke to offset in terms of shortage with locums and tenant physicians. Let me ask you though, your staffing needs. What's being done in respect to helping you to fill a gap in addition to all that you have done in that space? Because it seems to be very challenging. I know there's a shortage everywhere, and you have been creative in some ways. What else are you doing to help to fill that gap, fill that void?
Yeah, thank you, Senator Blyden. And we could probably have a 3-day conference related to this topic. In healthcare, it's becoming very challenging for a lot of reasons, not only in St. Croix, but across this country. That with the growing age of our nursing population, with the growing age of our physician base, more and more of our caregivers are leaving the field, specifically because of burnout and just the work demands. So every organization is grappling about how we go about fixing this. I'm very happy to see that we were successful at renegotiating several of our union contracts. But money is not always the key driver to everyone. It's lifestyle. It's being flexible in how we do things. People have a lot of demands outside of work. So how do we go about creating flexible schedules so that we can not self-limit our ability to hire good quality people that are here locally? And that we also talked in our testimony about promoting from within and advancing our own people into new positions. And I think that's a key thing that organization and culture needs to do, is our employees need to know that we are behind them and that we're going to engage in them and invest in them for their future as well.
Let me ask you, since you're speaking to that, your student convention, are those high school students or are those college students?
That program was specifically designed around the high school students. And I think we had 5 different schools represented, and the goal was to get them interested in healthcare fields.
How did it work out?
Oh, I thought it was amazing. I had the fortune that they came to let me do the opening statement for it, and to see 65 kids in a room that were asking engaged questions about healthcare and jobs as nurses or as technologists. I commend that team for putting that together.
Was it territory-wide or just the St. Croix district?
I believe it was just St. Croix district.
Okay, very well. I'd like to see that happen on this. And also, I think that's a very, very good idea. And that's the way to think outside of the box. Let me ask you though, because despite all that you're doing, you still have a $16.3 million shortfall in terms of cash flow challenge when it comes to staffing agencies. Can you speak a little bit about that and what's happening in that space?
Yeah, so a couple things there. We've had a series of physicians. Again, we talked about the slow transition of some of our physicians out of their practices. So the locum agency expense is a portion of that. We are happy to say that we reduced from 58 traveling nurses and techs down to, I think we're at about 20 right now. One of the things that is embedded within that 20, though, is a program where we bring them on as an agency person, but they sign a contract that they're going to convert to a full-time employee. And so it's kind of a on-the-job training for a period of weeks, and then we bring them on as a full-time employee. So that's another unique thing that we're doing.
Very well. Thanks. Good to hear that. Let me ask you in respect to your outpatient services and the challenge you have in that area and trying to reclaim a percentage of the market. What are the type of services you're speaking to, and what percentage of the market is your target in terms of reclaiming to start with?
Thank you. I'll be quick. Was basically speaking of outpatient surgical cases. As a hospital used to be one of the only providers of outpatient surgery, with the advancement of technology in healthcare space, you can do more and more procedures on an outpatient basis. So, and we've seen that over not only in the 2 years that I've been here, but probably over the last 10 years, where you see a kind of a migration of procedures and cases away from the hospital that can be done within private offices or surgery centers. And our goal, and that's fine. I mean, that there should always be competition, but it's our job as a hospital to work to reclaim a portion of that business.
And what have you done to decrease your borders from 10 to 4? What did you do?
You know, it's not me. It's the amazing people that work around this on a daily basis. It's our case management team. It's the Department of Health and Human Services, the Department of Health, private agencies. We're working collaboratively with so many different groups to find every border is a unique situation, whether it's their personal life or their health condition,
1 minute.
their home environment. You have to work on an individual basis for these cases. And I'm also happy to report the number as of today went down to 3. So we continue to make progress.
Okay, very well. Director Small, Executive Director Small, first I want to thank you for the work you have been doing thus far. And for the CKCI, I've seen the work actually that they have done in terms of securing the place. And safety is very important, and I'm happy to see what they're doing. Let me ask you, though, quickly, in terms of the total separation, to basically assure that you have the storage, medical records, business office, etc. What will that do in terms of the structure, and why was that decision made? It's just my curiosity, basically.
Okay. Originally, when we constructed the CKCI, it was connected to Royal Schneider Hospital for water and a lot of the systems. With the fact that we're going to be reconstructing the Royal Schneider Hospital, we wanted to ensure uninterrupted delivery of service for CKCI. So as a standalone facility, it has its own mechanical systems, its own water treatment, water distribution, electrical, generating backup. So whatever is happening within Royal Schneider Hospital, it will not have any impacts on CKCI.
And that was part of the original plan?
Yes, it was part of the original plan. Obviously, I was involved with the original construction of CKCI. It worked at that time, but as we continue to be impacted, whether it be storms or events locally with the utility companies or any type of interruption, it disrupted the services of CKCI. So by becoming a standalone facility, hardened, resilient, we hope that regardless of any type of catastrophic event, that we'll be able to continue to provide service within that facility.
Well, it makes sense, and I appreciate the work that all of you have been doing in the healthcare space, and thank you so much for your responses and your dedication to the people of the Virgin Islands. Thank you so much, Mr. Chair, for the time.
Thank you.
Thank you, Senator Blyden. And I want to, piggyback on what the senator just said, right? And I'm talking to the community, right? There's nowhere else in the entire Caribbean that is investing as much money in new hospitals and new clinics than right here in the Virgin Islands. We are going to be at that point. We just have to get there. But in the near future, the Virgin Islands should be top-notch as far as healthcare facilities in the whole Caribbean. Like I said, I don't want to spit out the numbers, right? But we are investing a tremendous amount. Thank God, that we're part of the United States, because without the federal government helping us, we would be in a predicament. So we're going to get there. I wanted to go Doug Cook real quick before I go to the next senator, because I want to get the numbers clear, and you only have one bite of this apple. because we want to move this here, and with right now, my information is showing that there's 102 kidney dialysis patients on St. Croix. Juan Louis is treating 42 of them, and Caribbean Kidney Center is treating 60, more or less. Are those the numbers?
That's more or less correct, sir.
Okay, good. So now you're asking here for approximately $1.4 million, and you're going to get new dialysis equipment. You know, you got to build a facility, drugs, supplies, staffing, etc. So what you're telling the committee now is that once you get that, you will be able to treat all those 102 kidney dialysis patients on St. Croix?
Yes, sir. Is my mic on? Okay.
Yes, the answer is yes. I want to make sure the stenographer record that Doug Cook says yes.
So
Because
it's there's more to the answer than that, sir. That is relatively to our emergency plan of being able to stand up services if, for some reason, JFL had to support all services, all dialysis services on the island of St. Croix. So that is one plan. We also are fortunate enough that we have an active PW that is actively being worked on through the work with Director Smalls to move our entire dialysis program to the Princess location, and that will cost well above the $1.4 million you referenced, but that is covered under the PW.
okay, wow, that's great. I'm glad to know this, because in addition to that, there's another facility that I'm going to recommend the committee also fund that is in the process of setting up a kidney operation there. I'm not going to call the name, but there's another one. So basically, because potentially we could be in a real serious emergency now if the private firm that's treating the patients decide to close. Because we had a court case, we took them to court, the government prevented them from closing, and now I just want to make sure that number is still good, because we're going to act on that. It's about 1.4 million. If that number is not good, then come back to me as soon as you can, so we have a good number, so that when it moves, it's a good number. Okay, good. So Doug Cook is saying yes, and that's a yes,
Yes,
right?
sir.
Good. Thank you. Blessings. So we'll go to the next senator, Senator Diane Capehart. You're recognized for your 8 minutes.
Thank you, Mr. Chair, and good afternoon, colleagues. Good afternoon, testifiers. Good afternoon, Director Cook and your team. I wanted to first go into questioning as to Mr. Smalls. You mentioned about some of the leases and infrastructure projects that are going on at the Cassava Garden. How long is that lease for?
Good afternoon, Senator. That lease is for the duration of the reconstruction of the Juan F. Louis Hospital.
So, in other words, if this hospital is to take 5 years, it's for 5 years. So however long it takes to build the hospital, that's the duration of that lease?
Yes, Senator.
Okay, good. And then you mentioned, I didn't have the testimony while you were reading, you also mentioned bids were just recently sent out for St. Thomas. How many bids did you receive?
Senator, we're involved, with all due respect, we're involved in an active solicitation. I'm not at liberty to discuss the number of respondents.
Well, through the chair, if you could please provide that information, we would appreciate that.
Yes, through the chair.
Through the chair. Director Cook, in your testimony for quality and service, one thing that jumped out at me was the two trauma beds. How much money does the territory spend in sending our trauma patients out of the territory? Do you have that number?
I do not have that number specifically regarding trauma available, but we'd be happy to research that and get that to you.
Yes, please, through the chair. And also, have you had any conversations with hospitals on the mainland to actually assist with to improving our trauma unit here in the Virgin Islands?
We have active conversations with mainland hospitals ongoing, usually related to the transfer of patient care back and forth. The great staff that we have, I would say the staff and physicians that we have here at JFL are very capable of handling trauma cases. It's usually the cases that get transferred off are where we don't have a specialist, whether it be a specialty such as a interventional cardiologist or a neurosurgeon or a trauma surgeon that needs those patients need special care for.
So, thank you for stating those positions that are in need. So are you working to fill these positions for these specialty doctors?
Actively, but not for all of them. I think that's a conversation that us in healthcare and this community need to have. Will we ever do brain surgery here in this community? Probably not, because it's not safe, because you need to do a number of those cases, and we don't have the resources or the teams to be even to develop that. Just like cardiac surgery, in my opinion, we should not do cardiac surgery on this island, because a cardiac surgeon needs to do at least 100 cardiac cases to keep his skills and his or her skills and that of their team up to fruition. And that's hard for us to demonstrate that level of need for this community. But we should be able to handle everything up until that point.
Mr. Cook, you mentioned that JFL has not received the official survey reports from CMS. Have you requested those survey reports?
Yes, recently, as of about 2 to 3 weeks ago, I had the conversation with the lead surveyor from Region 2, and they're actively working on it. They're following up on some questions on their end. We provided them some additional information. So, but they gave us I would say, a good list of preliminary process improvement things that we can work on already that we expect to be in the final report. So we're well on our way to working on those.
And correct me if I'm wrong, did you mention anything, you mentioned about borders and the hospital? How do you handle patients that come in with behavioral challenges that, say, the Department of Health or Police Department bring these individuals to the hospital? If you could just take us through what happens with these individuals on that day. Are they allowed to stay 1 day, 2 days, 3 days based on their assessment?
Yeah, so, and you use the key word there, Senator, and thanks for that. It's all about the assessment. So we have a psychologist on staff that would get the referral to see those patients. We have a 4-room holding observation unit within our emergency room. So our nursing teams would be able to care for those patients and observe for them while that assessment is being done. 2 things can happen from that. They can determine that the patient needs outpatient services that are need to be identified either in the community or off island, or the patient needs additional services, inpatient services. Then we work closely with our sister hospital, Schneider Regional Medical Center, who actually has an inpatient behavioral health unit, and they would take those patients if they have the capacity to do so. So it goes based upon the assessment of the patient.
Thank you. You mentioned the Little La Grande Princess Dialysis Center will be completed. Do you have an idea when and where is this actually located?
Great question. Since I'm relatively new to St. Croix, it's been about 2 years, I'm told it's the old Nissan building. So if that helps you in that determination. But I will let Director Smalls answer the question relative to the timeline.
Good afternoon.
Please, because I have 1 minute left and I have a few questions left.
All right. Good afternoon, Senator. We recently completed a solicitation and notified an architect of award. So once that contract is executed, we start to develop the plans. We hope to have a solicitation once the contract is executed within 3 weeks or less, a solicitation to begin the construction process. All of this is slated to be completed by the fourth quarter of this calendar year.
Okay, thank you. Let's talk about hospital presumptive eligibility. Can you tell me the hospital employees were trained on hospital presumptive eligibility?
Yes,
Tinkoya and St. Thomas, yes?
yes, they are trained regularly.
Are the hospitals making sure that they offer hospital presumptive eligibility to those clients that come through your doors?
Yes, you do. Sorry, this is Chris Lewis speaking.
Pull up the mic.
Yes, we do. Are you hearing me?
Yes.
Media, recognize the mic for all the testifiers on St.
Time.
Thomas.
Media, recognize the mic. Go ahead.
Okay. And this is Chris Lewis, Senior Vice President of Finance. And yes, we do. We ensure we also added a questionnaire that the employee checks yes or no on whether they've inquired about whether they're eligible for MAP.
And Senator, if I may add on to that, we recently, a few weeks ago, had a meeting with MAP, as we do regularly, and they actually commended us on our process related to presumptive eligibility.
Correct.
So through the chair, can you also give that dollar amount as to what CMS is assisting the territory with presumptive eligibility?
Yes.
Okay. And Mr. Chair, if I may ask one final question, and this question is to Mr. Christopher Lewis. You mentioned that there's a problem with Gaineswell and Medicaid, a technical issue, and I'm kind of confused because if there's a problem with a technical problem with Gaineswell and Medicaid that the hospital needs $7 million, I think CMS needs to be in a conversation. I think the commissioner designee, Ms. George, needs to be in a conversation with the hospital. This is an urgent matter. And from November is what I'm hearing. November, we need help. You know, you guys, it's across the whole U.S. Hospitals are facing the same financial challenges. And if we have money to get, we need to get it. We cannot let individuals, just take their time to get the money. $7 million, that's a lot of money that the hospitals need. Thank you, Mr. Chair. I will ask questions if we have a second round. Thank you.
Yes, Senator Caput, I just wanted to make certain the request through the chair. So I'll repeat what we wrote down here, just to make certain. So the first request is for the how long the lease is, the duration, the rebuild of the hospital. That was the first request. Senator Caput, so the first one is how long is the lease, the duration, and the rebuild, and then provide how many bids they receive for the hospital rebuild, and then also the numbers Wang requested. Is that the request?
For presumptive eligibility?
Oh, and then the hospital presumptive
Yes.
eligibility. Doug, you clear? Mr. Cook, you clear on that?
Yes, just one clarification related to presumptive eligibility. I think it was asked for Medicare. It's actually Medicaid. Maybe I just heard it wrong, but it's Medicaid, and we'll provide that number.
Mr. Cook, I definitely know Medicare and Medicaid. Definitely Medicaid.
Yes, that's right, Senator.
And what was the
Used to be-
dollar amount question asked?
Clarification, yes,
was-
Medicaid.
I wanted to follow up with that $7 million for the Medicaid, Mr. Cook. I want to follow up with that $7 million. So you're saying since November, they haven't paid you? Or they've partially paid you?
We've been getting small payments trickling in that we weren't getting the 835s to. So we weren't able to differentiate between, you know, what we were actually being billed for and what was being paid for. But we've recently got those remits caught up. So everything that we've got through the system is where I then took whatever's still pending from our MAP payments from fiscal year '24, going back to 365 days. That's what I'm showing is still open in our system.
Okay, and then prior to November, how were the payments? Were the payments relatively on time?
Yes,
Or so the problem started in November?
Correct. It was October, November timeframe is when we started noticing it.
Okay, well, I think April 15th coming soon, so maybe the payments will speed up, but that's not good. But, you know, I'm not going to discharge you from your responsibility to collect.
No.
So tell me now, what information do you need additional to be able to collect, or is just that, you know, you have a problem with people just not paying you? Tell me what's going on there.
We're not having, if you look at our overall collections, like we brought up before, our collections at 23 from the same time frame compared to last year, our collections have gone up almost $2 million and from our commercial payers. But that difference is we haven't been receiving those full tranche of Medicaid payments to where we would usually get, you know, 1.2 to 1.5 million toward the end of the month, and then in the middle of the month we would get our ESRD, which is usually $300,000 to $400,000. And so we've been getting little $100,000, $200,000 payments coming in, trickling through, but we don't know exactly what those are for yet.
Okay, so you tell me basically that 52% decrease in Medicaid payments is really the big problem that you're
Correct,
facing.
and that will go up substantially once whatever that technical issue is resolved that
Okay.
Medicaid is working on with Gainesville.
Well, I think April 15 coming soon.
And Senator
Hopefully
Fonseca, if I
that will
may
fix
just
that.
add on to that, and goes back to a question that Senator Capehart asked, we understand very clearly the emergency situation this is. That's why thank you to the senators for allowing the emergency meeting we had a few weeks ago related to this topic. We've also had a meeting with Commissioner nominee George and her team related to this. I think that, and even to the governor's office, we have activated all sources to address this issue. And we stand ready to work in partnership with anybody that can help assist with us.
Yeah, I hear you, Mr. Cook, but I'm still very concerned because I can't see how you can continue to operate the hospital just, you know, being outstanding $7 million just from November. And it keeps accumulating. So I know you've had the meetings, but, you know, we cannot afford for the hospital to get in any worse financial shape, because next thing you know, you're not going to be able to meet payroll or pay the benefits, and, you know, that brings us a downward spiral. Remember, we just went through that with East End Medical Center, where we had to give them an infusion of $2 million in ARPA funds. Is Wang Louis Hospital in a similar situation like that?
We are in a very difficult position financially. As Chris mentioned earlier, we are working with our vendors. We are partnering with them. Some have been great about giving us a grace period until we're able to, it's a cash flow issue. We are getting cash in, but not always at the right time. So it's definitely a balancing act, and we appreciate your sense of urgency as well.
Okay, well, after the meeting, we'll make a call to the OMB director and to the Medicaid director and see what's happening, because $7 million is a lot, and that's just, going back 5 months. Okay, so we'll go to the next senator, Senator Milton Potter. You're recognized for your 8 minutes. Media, recognize the mic for Senator Potter.
One. Okay. Thank you very much. Good afternoon, colleagues. A special good afternoon to CEO Cook, Mr. Smalls, ED Smalls, as well as the executive team from the Wang Lui Hospital. I really want to start by saying kudos to you, CEO Cook. You mentioned in your presentation that you were able to fill 60 positions during FY 2024. And I know that just the whole idea of recruiting and the recruitment and retention of medical professionals, even in cities throughout the United States, is a challenge, much less for us in a rural island community. So I want to give you kudos for that. You mentioned in your presentation that you hired a full-time physician recruiter, and I wanted to know how long has that person been on board, what's the salary, and how has that been working out for you?
I can start to answer that. I will turn it over to our interim chief medical officer, Dr. Mavis Matthew. That position reports to her. But I can tell you that the person's only been on board for relatively a few weeks.
Okay.
So there isn't results there yet. She's still in basically orientation.
Understood.
Okay.
Understood. And if Ms. Matthew can tell me how that person interacts with HR.
Davis Matthew, Chief Medical Officer, Pro Temp. The person has joined us 2 weeks. She's here in the audience so that she can understand the interactions and move on with the business of recruiting physicians with the urgent need. Her salary is about $73,000. And just to wrap it up, we want to place her in areas where it can get her to work with the federal government through the National Health Service Corps placement persons, J-1 visa recruitments, and some out-of-the-box recruitment efforts in addition to the usual recruitment of physicians. Persons who live in the Virgin Islands and have gone away for training do contact us. She's made contact with them. It is a great resource. They're nearby in Florida that like to come home and help build a system. So she is being placed to do undistracted work in terms of recruitment, not locum tenens and the change in day to day, but to get the infrastructure solidified.
Understood. Have you had that position before, to your knowledge, in the history of JFL?
I don't know of that position. The HR director is here. It was in the health department. We did have that designation many years ago as a National Health Service Corps, but since the hospital and health split, I don't know of the hospital having that designation recently.
I definitely want to commend you because I think in these challenging days, based on where we are, it's important to be creative and to think outside the box. This is something new that we're trying, and I think that and I pray that it bears fruit. So I just want to extend kudos to you on that. How many key vacancies do you have remaining?
I can, thank you, Senator Doug Cook. I can turn that over to our Chief Human Resource Officer to give you an accurate number. I think that it's a number that is always in flux based upon having just enough staff.
Yes. But I mean, those real key critical positions.
Yeah.
I know you
real key critical positions. I think we're talking about the 20s and 30s.
Okay.
Around those type of numbers.
Like what type of position were you talking
And we're
about?
talking about key nursing positions and allied health positions. So X-ray techs, respiratory people, those more allied health areas.
Okay. Fair enough. I wanted to ask you, Director Smalls, now that Director Williams, or Actalin Williams, was here a couple weeks ago before the Committee on Disaster Recovery, and we were talking about Rebuild USVI, and that's the governor's bundling initiative, where his hopes is that we would be able to recruit larger, experienced contracting firms to assist with the rebuilding of our territory. And as you know, the major rebuilding effort for us, our territory, is hospitals. So I was curious to know if you were playing a role in that whole process? Are you a part of the discussions? They were talking about a project management office, standing up a project management office. What role will you play in the overall development of our hospitals in light of where we're going with this rebundling project?
Good afternoon, Senator, and thank you for that question. I've actually been working collaboratively with the director as well as the team. There's a lot of moving parts there. We almost been meeting 2-3 times a week. I've been engaged with them. As a matter of fact, following this hearing, I'll be going into a meeting with them. So I would say the discussions and the engagement is continuing.
Okay. So you have a direct role. I know the expertise that you have, I guess, acquired over the years will be instrumental in this process moving along smoothly. What strategies, Mr. Cook, are you considering, most significant strategies that you're considering to improve the financial sustainability of JFL? And I know this is a challenging period for the hospitals, but what specific strategy would you say that you are counting on to ensure the financial sustainability of the hospital?
Several. So number one is about reimbursement. We know that our we know that our Medicaid numbers are capped at a specific dollar amount. So what we need to do there is maximize the number of patients that we have. We need to bring in more commercial business. And so we have a strategy on how we grow our outpatient business and attract more commercial business. That is where we're going to see the biggest benefit for our organization. There's a lot that goes into that because you have to recruit not only the right specialties to have that available, but you then have to have the nursing and the support teams and the technology. So in a basic hospital, you should have a fluoroscopy radiology piece of equipment. JFL does not have one. It is an essential basic function of a hospital, and we are operating without one. So making sure that our physicians, and to be able to attract physicians, we need to have the right infrastructure and the right technology available.
Excellent. The Schneider, the Cancer Center, Kimmelman Center, I was happy to hear that we're projecting, I believe you said 2024, September 3rd, 2025, yes, as a completion date of that hospital. I was almost nervous to get excited because it just seems like that's around the corner, Director Small. So is that, I mean, from your experience, is that a realistic time frame that we can expect to see the completion of that hospital, of that cancer center?
Senator, from a construction standpoint, I'm not concerned. We have an excellent contractor on board, and being able to get the project completed, I'm confident with that. I think my greatest concern is the long lead items and the equipment. This equipment is not anything that's on the shelf. It has to be manufactured. Components are coming from different components in the world, and then they're assembled on the mainland, and then having to be shipped here and then installed. That is our greatest challenge, our greatest concern, and we continue to work on that schedule.
Okay, my final question related to this, and I know it's one thing to stand up a cancer center, which is critical here in our territory. Everyone knows somebody who's suffering from cancer and has to fly off island during very difficult circumstances. Are we, and this might be outside of your wheelhouse, are we working simultaneously to address the staffing of this hospital, of this cancer center, once it stands up? I mean, is that happening like right now, or are we going to be saying, okay, now that it's built, we're trying hard to find and having challenges recruiting critical personnel?
Those discussions have been ongoing for quite some time, and now that we have a time certain of when the center is supposed to be completed, I know that the leadership team is actively involved in discussions and planning for that effort. Especially that's going into the next fiscal year, and from a financial planning and what have you, HR standpoint, I know that they are working towards that.
Thank you very much to the team for your efforts. This is not an easy job, so I appreciate the efforts and the work that you're putting in to make sure that the territory has adequate healthcare service. Health is everything. Thank you very much, Mr. Chair.
Thank you, Senator Potter. Quickly, Mr. Cook, CEO Cook, the Registered Nurse Leadership Union, they are not too happy being that the nurses, got a renegotiated compensation, and some of the nurses are now making more than the supervisors. So how close are you to being able to finalize that deal with the nurse leadership?
Yeah, thank you for the question, and I totally agree with you. Our nurse leaders do an amazing job, and they deserve to be well compensated, and I think the process has taken too long. I think it goes back and forth on both sides, but happy to say that both everybody has signed off on the contract or the agreement, and it is now on the governor's desk for his signature. So as soon as that gets processed, we're good to go.
Okay, that's good. Quickly, MRI and CAT scan. Does the Wang Louis North have an MRI and a CAT scan?
Juan F. Louis has a 64-slice CAT scan. It's probably the fastest on island. And we do not have MRI services available at Juan F. Louis Hospital. I'm sorry, it's 128 slice.
Okay, good.
I
Yeah.
have it.
And that's important, right, Mr. Smalls, because I keep letting the community know, right? And correct me if I'm wrong. If you go to, let's say you go to Mayo Clinic, what slice CAT scan are they using up there? Do you know?
We don't know specifically. I'm actually an X-ray technologist, so I have a fair amount of knowledge in this. Once you get above 64 slices, they're all doing relatively the same, but you really want a higher slice value so you can decrease your per second slices per second. And once you get up to 128, 256, and they actually have 512s out, you're really looking at motion studies and really trying to get into beating hearts and being able to do more coronary stuff. But you can actually do those coronary studies on a 128 as well.
Okay, let me break that down a little bit for the community, because a lot of us don't have a PhD. But if you take, like, this is an inch, right? Mr. Cook is giving testimony that within this space here, their CAT scan can take 126 pictures
per second.
In just that. So, we relatively have similar machines to the best of the clinic. So it's not that you're getting, any better diagnostic treatment, And like I said, we're getting to the point where, the Virgin Islands, we're going to have state-of-the-art hospital facilities. As a matter of fact, right now, the Wang Louis North is a state-of-the-art. So real quickly, I don't know if Mr. Smalls can give me this, but with the new Wang Louis construction, the cardiac center, give me some more information, some specifics on the cardiac center. What specialized treatment we're going to be able to offer?
Well, due to the construction that went into the original VICC, that facility was not impacted by the storm. As such, it did not receive any federal funding as a result to do any repairs or upgrades. However, because it is a comprehensive site that we will be looking at with the brand new JFL facility, you can be sure that you're going to see improvements within that facility as well.
Okay, that's good to know. Okay, we'll go to Senator Gittins, Vice Chair Gittins. You recognize. Senator Caput, point of information, you're recognized.
Thank you, Mr. Chair. It's hard to ask for a point of information from over here. I just wanted to do a follow-up question to Dr. Mavis Matthew. You just gave us some good news that you just onboarded a new staffer to assist with recruiting physicians. That is correct?
Yes, Senator.
So what are you guys doing differently to recruit doctors? And were there any challenges as to why we didn't have or why we don't have a lot of specialty doctors? I don't know. I just want that clarification here because, I've been told there are union issues, there are problems with the board. Can you let us know that the process or the recruitment process to get these physicians here? Like more salary, better benefits? Can you let us know?
Well, yes, Senator, you identified some of the standing issues. Of course, the salaries for the physicians has been outdated. The unionized physicians haven't had an increase, I believe, in many years, and the contract is like 2007. So they work from a baseline, and then they have to supplement their own income with additional work. The model is not competitive any longer. When I came home, and that's 1987, that was the model that was used because they wanted to encourage us to own offices. So you would get a stipend and then you'd go and have your office. But persons are now interested no longer in opening offices in that sense. They would like to become fully employed by the hospital. So we have designed a pay scale, and we're looking to adopt a unilateral pay scale between St. Croix and St. Thomas. Funding is critical. So that's one thing that's different, but I think it is contemporary. It's what the physicians who are coming out of residency now are more likely to buy into. What is exciting to me about having the recruiter is that we want to get into the systems issue. With the J-1 visa, that person has to sign on for a 5-year commitment. This is through the immigration system. And Senator James, you know very well about that. And that's rich. That's a rich potential source of physicians that we have not tapped recently. And I am very excited to have someone to work in that regard.
Okay, thank you. Thank you, Mr. Chair.
Okay, thank you, Senator Capehart. Senator Gittins, you're recognized for your 8 minutes.
Thank you. Thank you, Mr. Chair, and good afternoon to all. Disappointed I am listening to the information. Our people needs help. We need help, and we want to stay here in the territory. I am not certain why things move so slowly in my homeland. I really don't know. But I always say that people need to get up off of what they're sitting on and get things moving. And the process that I'm hearing, or the so-called updates, I am not comfortable with. Totally not. I expected to hear more firm timelines on the build or even the demolition of these properties. Do we have a demolition date in place for JFL St. Croix?
Good afternoon, Senator. No, we do not have a definitive date today.
How soon would we have this? This is years later, and again, part of my disappointment, because if we don't know when we're going to knock it down, we don't know when we're going to start to build.
Senator, I could understand your frustration. However, I need to provide some clarity there. The funds that we have are federal funds, and the federal funds require us to go through a number of procedures prior to even issuing a solicitation. We're talking about environmental issues, we're talking about historical issues, a number of things that while we want to see expediency, we have to clear all of those hurdles first before we can actually issue a solicitation.
So let's put a pin right there. I understand the bureaucracy that we have to go through with the federal government, with the federal dollars, etc. Are we meeting every deadline that we're supposed to meet with regards to this process?
I would say yes, we are, Senator.
So then the hold up is not on this end.
I wouldn't say there's a hold up. It's ensuring that we cross all our T's and dot all our I's. What we do not want to happen is that we issue a solicitation and then the federal government comes back and says, well, your what you've expended is ineligible, and then the territory is on the hook.
So you don't have someone from on the federal side working side by side with someone at JFL so that we can move this process along a little faster and smoother?
Senator, that is why the THRT was established. We work hand in hand with FEMA, with all of the federal bodies to make sure that we get everything in place. Currently, JFL is out for solicitation. So once that solicitation is completed, then I will be able to come back and provide some more definitive timelines.
Let's move to St. John. $37 million received from FEMA. But there was no additional real information. What's the plan for St. Johnnians to be able to have a healthcare facility here on St. John?
As I reported, Senator, that solicitation we're looking forward is projected to be going out the third quarter of this fiscal year, or this calendar year, I'm sorry.
And your third quarter means what month?
Between July, by the end of September.
CEO, some of the questions were asked, but I'm going to go in a different angle because several of my colleagues asked about what are you doing differently to recruit physicians and whatnot. Now, you said that you hired a physician recruiter. How many physician recruiters do you have?
We have 2 physician recruiters that report to Dr. Mavis Matthew.
2 physician recruiters?
Yes, sir. What we found is the first physician recruiter we have spends almost all of her time lining up locums and agencies and dealing with that thing that we're not able to go after these types of programs.
So, and I'm going to come back to locums. So we have 2 physician recruiters. What experience or credentials does these individuals come with for recruiting the right physicians?
Yeah, I'll turn it over to Dr. Mavis Matthews since those physicians report to her.
Dr. Metro?
The credentials that are required, first of all, is to be organized and to be able to speak well and relate to persons so that they can be engaged in the process. The long-term recruitment development we have online is credential training. So the Senator, your point is well taken about having a formalized program, but right now we are moving with the J1 visa program. We're using the healthcare shortage manpower program through the Department of Health. Those are established programs that you don't have to have a specific credential to be able to access them.
All right.
And I'm speaking about the person who's going to be running the program.
All right. And good doctor, you know I have the utmost respect for you, but I don't like this one bit. It doesn't sound right or fit right with me.
1 minute.
But I will trust that whatever you have in place, that you all will know exactly what you're looking for and what our needs are. Let's go over quickly to the Omnicells. I'm always asking you about the Omnicells. Are they working now that you've moved over to JFL North?
Yes, our Omnicells are functioning.
All are functioning, and we're capturing all data for charges regarding the supplies.
Yeah, we can talk to nursing or to materials management, but what we found, they're all functioning. What we find is it's a constant update of them. So on labor delivery, one of the things we did as part of our audit, we found that through the charge master system, some of the charges weren't captured. Now, we're not losing those charges. We put together a manual process to be able to capture those, but we have a nursing team and a materials management team or a charge master team that are working through those to identify which charges, which supplies are not coming through to rectify the situation That involves our IT team and the
Who's responsible?
Omnicell.
Who's responsible for this information?
That would be between the nursing unit and the materials management team.
So that's 2 units, but who is responsible for the Omni cells?
So
This data.
it's Rochelle Lewis is the Director of Materials Management, and then on the nursing side, it would go up to Chief Nurse Doris Plaskett.
So MIS and no other entity will have any input with capturing this data.
IT will have an input into it as well as Omnicell, the company as well.
So who specifically, who is a person, the go-to person for these, for this Omnicell system?
I would say it's Rochelle Lewis who is responsible for materials management, and that's where the Omnicells start. But it's, it's a collaborative effort because nursing is also responsible for the products that go into it. So if we switch products, et cetera, it's a collaborative effort.
Time has called, Mr. Chair.
You may finish up. You may finish up, yes.
Listen, it's so much, but let me ask one more. So you stated that CMS made an inspection in December?
Yes, sir.
And we're in April, and we have not gotten a report from their inspection in December?
They were here at the end of December, and then they...
Okay, so we give you January. So we're in April. We still have no report on what their findings were?
So they came back in January to do the life safety portion of this survey. Yes, we still do not have a report, a final report.
How soon do you expect to receive this?
My conversation with CMS 2 to 3 weeks ago was that they are working to finalize things. They had some additional questions for us. We provided them some additional information. I would expect it relatively soon.
Mr. Chair, I beg your indulgence here.
Yes.
How many emergency room doctors we have at JFL?
4.
Doris, do you know that answer?
No, but that much.
Dr. Mavis Matthew, do you know how many emergency room physicians we have on staff?
We have 4 on staff.
How many?
4 on staff, full-time.
4 full-time. So, and they're not locums?
They are not locums.
Good. What is the current wait time? The max to the minimum.
This Doris Plaskett, Chief Nursing Officer. We can run up to, the average is about 2 hours.
2 hours what?
Waiting time in the emergency room.
That's the max or the minimum?
No, that is not the max. That is the average. The average waiting time is about 2 hours. When we talk about waiting time, there are many factors that you have to take into consideration. In the emergency room, you have different levels of patients that are coming in with different needs. So the waiting time for someone that is a trauma or cardiac, what we call like the level 1, that is immediately attended to. Now, when you look at your non-emergent cases, it just depends on how many people are waiting to be seen at the time. If we don't have a lot of patients waiting to be seen, that could be 30 minutes.
You know, I just beg to differ because I never heard about 2 hours wait time. And I prefer for us to just be upfront. Because every time I call your phone, CEO, or even call your phone, it's always because somebody has been there in excess of 6 and 8 hours. I've never called for anything lower than that. So to hear the average wait time is 2 hours, I don't buy that. And this is why I've suggested before when we had the off-camera meetings and whatnot, I've suggested that we get a little more high tech and put up a monitor where patients or people can track how long someone has been waiting and when you go move on to the next step. Are we doing this now that we've moved over to JFL North or no?
We have not started that program yet. It has to come with the Meditech Expanse upgrade, our next IT upgrade. Our current module does not account for that. So we heard you, and it's being provided in most all urgent cares and emergency rooms across the country, and we expect to provide that as well.
So I'll just ask this and then I'll stop until if we have another time. How many locums we have?
Dr. Mavis Matthew?
And
are you speaking specifically of the emergency room or in all?
In all. And locums are traveling doctors, correct? So that the folks watching and listening could understand.
Dr. Matthew?
Matthew, CMO, in any given month, we may have about 20 locums.
Wow. At what cost? What are the fees we're paying?
It averages to about $4 million a year.
Through the chair, can we have this information from JFL regarding the locums and what we're paying for this program, please?
Yes, through the chair, you understand the request, Mr.
Yes, sir.
Cook?
Yes, sir.
Thank you. I'll yield.
Okay, thank you very kindly, Mr. Vice Chair, for those real important questions. I wanted to ask Dr. Matthew, real quick, you were talking about the goal was to obtain the healthcare professional shortage areas designation to be able to get those J1 visas. Has Wang Louis been officially designated as such?
No, that's what we're going for, that application. So we're working with the health department.
Okay, and then the health department works with immigration. Can you explain to me how the steps go in that? Dr. Matthew, Director Cook, can you explain the process to be able to get that designation so we can issue the J1 visa program?
Well, the J1 visa program is actually a separate program than what you're speaking of through the Department of Health. We already meet the qualifications for the J1 visa program, so it's just identifying the physicians that qualify and that are interested in working in the Virgin Islands, and that's a large part of what the physician recruiter will be doing, is researching that and putting together. It's an extensive application process that we have to go through to be able to support someone on a J1 visa.
Okay. You know, I did a quick math there, Dr. Matthew. You said it's costing you about $4 million, and there's about 20 of those locums, right? So that's only about $200,000 a year. So that's kind of low. I mean, are those locum full-time physicians or are they just part-time?
They're definitely not full-time senators. They work days at a time, and you can add an additional about 1.4 million costs for other accommodations, car, hotel, and what have you.
Okay, good. I'm glad you clarified that because, you know, I don't have a PhD, but I like to add and think I have a calculator here. Okay, so I wanted to go back to the budget. So I understand you have the $7 million for the Medicaid. How about your regular OMB allocations? How are those coming? Are you on time or how are you?
We are current.
You're current.
Through March, yes. We received the March allotment last week.
Speak in the mic, I can't hear you.
Sorry, Chris Lewis, Senior Vice President of Finance. We are current on our allotments. We received the March allotment last week, so we are current as of today. And we also received the Board of Directors $150,000 for fiscal year '24 by check.
Okay. Before I go to the next Senator, carry on. One question. So what are your total accounts payables right now?
I have two different numbers. I have a number that I carry that includes interest and penalties with the IRB and GRS, and then I have one that is just including where we are currently with our payables as it is currently.
Wait a minute. Interest and penalties with IRB. So that means that you have taxes, withholding taxes, back due. How do you owe IRB?
JFL historically in the past has gone 3 or 4 years without paying IRB taxes, and we have been paying a $60,000 per pay period uptick to kind of keep that going because they obviously want more from us, but that's the most we can pay right now. And that was from the time frames of 2013 to 2015, I believe.
Okay. Notwithstanding the IRB, how about the regular accounts payable?
It's running, our accounts payable is running a little bit worse than it was prior due to the collections for Medicaid, but overall our collections, our accounts payable is about $20 million.
And how about GRS? How many are those?
We're not behind with GRS at all.
Okay, so you're up to date.
Correct.
Your employees, you provide a pension and you provide retirement benefits for your employees, GRS benefits. Are there any special packages that the top executive staff have? Any special benefit packets?
Not to my knowledge, no.
Okay, so both you and Mr. Cook, you get a GRS pension, or you have a separate package that they're...
Neither one of us are vested yet. I believe that takes 10 years, but we are still paying into it, and the hospital is still paying the 23.5% on our behalf.
Okay, so that's a 501k. What kind of package do you have?
It's not a 501k. It's just a standard GRS.
Okay, standard GRS. Okay, good. Senator Carrion, you're recognized for your 8 minutes.
Thank you, Mr. Chair, and good afternoon to the staff of JFL. I do have a few questions. First of all, I must say that average waiting time, 2 hours, wow. I would like to know who goes to the hospital and comes out in 2 hours being served, because, I mean, everybody that I know, and my own personal experience has not been 2 hours. But I hope and I pray that one day we get there. Hopefully we will. Director Small, I must say that I heard your response to one of my colleagues, a good senator from Frederickstead, in regards to the timeline. And your response kind of didn't sit too well with me. So I would like to maybe bring the question up again and inquire. Do you have set goalposts? For example, I know you mentioned that you have to wait in a bit, but what would you like to see as a timeline for the project that you have before you with regards to JFL?
Good afternoon, Senator. When you say the timeline for the project of JFL, you're talking about from the day that we receive the FEMA award to when we can get to construction?
Yeah, demolition, construction, your estimation based on your experience of what a project like this would take. In a perfect scenario, what would you like to see as the person that's leading this project?
For a hospital of this size, if we were constructing this on the mainland, we're talking just under 5 years. We're estimating about 5.5 years for this construction. I think one thing that I really need to bring to the forefront, and I'm pretty sure everyone is familiar with it, but typically in a disaster, a state, they pay for the recovery effort and are reimbursed by FEMA. Because we here in the Virgin Islands do not have the financial resources to have commenced with any of these activities, we had to wait until we get the FEMA awards and then go through all of the processes that are required to be able to expend those funds. There isn't a day, as I mentioned to the senator, that we're not answering questions, whether it be by the auditors, by FEMA. We call it RFIs, request for information. I mean, every day, every week, we are providing the necessary information, providing resources, providing procurement documents, bylaws. What is your CZM permit? What is your flood zone permit? I mean, you can go on and on and on. You take
Sorry to interrupt you, but you know, we're on a time here. So,
right. So just to say, if I had my way, it would be 6 months.
Providing some clarity. But I have to move on. So I know there's a number of documents, informations, and response, and there's a process for all that. When would you like to see the demolition take place?
It is my anticipation that demolition will commence before the end of this calendar year.
And the hospital calendar year ends when?
No, the calendar year, December 2024.
Oh, calendar year, sorry. The calendar year, which will be December. Apologize for that. Okay, beautiful. And how long would you think the demolition will take?
The demolition is less than a year.
Less than a year. So then we're talking about then 2026, maybe the construction can begin.
That is my objective. Depending even on how we do the demolition, as we're doing the demolition, there's a possibility that we could commence with the actual construction.
Construction, very well. And then if everything goes well, you said 5.5 years, maybe.
Yes, Senator. There's a lot of obstacles, and as one of your colleagues asked about the territorial redevelopment, we're talking not just the hospitals, but the schools. We're all trying to utilize the same cement plants, all the resources. So it's a collaborative effort that we're doing across the territory to make sure that we streamline these processes to reconstruct our facilities.
So on the mainland, it's 5 years. Let's say it might be 7 years here in the Virgin Islands.
My challenge is to beat that. Like I said, under 5 years on the mainland, I'm not trying to go over 5.5 years, but everything has to align, our shipping, our storage, all of our on-island resources, manpower, everything that needs to be brought into the territory. Again,
are there any plans to place a microgrid on the grounds of the hospital when it comes to energy sustainability? What's the plan?
As part of our resiliency, we're also working with WAPA to develop microgrids across the territory within our facilities.
Glad to hear that. And then I think this is more for the finance department. Is the hospital owed money from other government agencies? What amount?
Okay. Chris Lewis, Senior Vice President of Finance. I can get that number for you. I know the Bureau of Corrections was the highest, I'm sorry, the Bureau of Labor, Department of Labor was our highest one, and we've actually settled on a $2.2 million through, I believe, fiscal year 2019 claims. And they're our highest one that we were told we would be receiving that payment sometime in fiscal year 24.
Okay, maybe just for essence of time, can you submit that through the chair?
Yes.
Thank you.
Yes, I'll give you entire
Now,
list.
patient satisfaction. I see that you've created within the division the patient experience department, which is the same for patients advocates, correct? It's the same department, just change the name?
Different focus.
1 minute.
Patient advocates typically focus on the back end on complaints. Patient experience is proactive and focuses on creating programs and experiences up front to make it a better overall experience.
I commend you for that. So that's a new initiative. So do you have any reports based on that?
I would like to turn that to Jay Rollins, Chief of Staff, who leads that program with his team.
Good afternoon, Senator Jay Rollins, Chief of Staff. We have unofficial numbers in our NRC scores. You'll see our trends trending up. We're seeing a decrease in grievances, tracking year to year. But this is a fairly new department within the last 4 months, and there's only 2 patient experience specialist.
So are you able to then measure from previous years to, because you don't have that data yet, right?
We don't have the data on the experience. What we have is the data on the grievances. So we'll do years with the number of grievances and how they're resolved.
Has decreased.
Yes.
Very well. Any lawsuits for JFL? Against?
Thank you for the question, Senator. This is Doug Cook. I don't believe Patricia Welcome is with us today. She's actually in another hearing. We do have pending litigation. I could not tell you the number of cases.
Very well.
Time?
I think, my time was just called. Overall, just in closing, areas that you feel proud about, that you've seen some improvements within the hospital, that you could sum up 3 of them.
I'm sorry, really quick. Did you say recruitments?
No, in general, challenges, improvements within the hospital that you feel proud about, if you could mention 3.
Yes, the opening of JFL North and being the transition of that within 1 year has been a great compliment to the team. I would say, again, the patient experience team that is doing so much for our patients and bringing those experiences back. And then finally, the work that's being done by our organization around employee engagement. Not only working on the salaries, but also working on all the things that go into what makes a JFL employee proud to be a JFL employee, because that's part of the overall employee engagement, and we have to have engagement employees if we're going to improve patient satisfaction.
Thank you. Thank you, Mr. Chair.
Thank you, Senator Carrion. Point of information, Senator Gittins.
Thank you, Mr. Chair. Through the chair, because as I continue to listen to these responses, it is about money. It's about the dollars. So we need to make sure that we're capturing every cent as well. So the Omnicells, you stated, who monitors them or who is responsible for the info is a nursing unit and material management, correct?
Yes, sir.
Who is the nursing unit manager?
Well, we have several of them. It depends on if you're speaking of a specific unit.
Okay, so different units. Who's the material management manager?
Rochelle Lewis.
And so the nursing unit will respond or answers to whom?
The nursing units report up to Doris Plaskett, chief nurse.
Who would those in the material management report to?
Rochelle Lewis reports up to Asa Victor, and who's our VP of Finance, and that has a dotted line then to me and to Chris.
So the information that we're not getting, who is getting and who to ensure that we capture this information?
May I speak on that? Chris Lewis, Senior Vice President of Finance. So my charge masters, when they received their latest update, started going through and meeting with each department. We started with radiology, and we started with lab, which was our most outpatient, where we had the most outpatient procedures coming through. And we've recently started working with nursing, where they started with labor and delivery. We found some items that we weren't billing for correctly that they found, that they're working with our billing team as well as with the nursing team and our IT, including the nurses as well as materials management. We're all working together now to go through each item to ensure that it's part of our charge capture correctly.
This material management unit, how many people are in there?
In total, I couldn't speak to that.
Who can speak to that?
I would turn that to our Chief of Human Resources, Patricia Canagata. I would say the numbers in that around 8 range, but Patricia, do you have that number?
Number of people in the material management unit, and are all those individuals full-time employees?
Media, please recognize the mic for the testifier, Ms. Patricia Canagata. Media, recognize all the mics on St. Croix, please. We still can't.
Senator, can you hear? Senator
Yes, we
Giddens?
can hear you now.
We have about 13 to 15 employees in the materials management unit in St. Croix, which includes the director, Rochelle Lewis.
Okay, so the director, Rochelle Lewis, you have a supervisor? Can we have 13 people in there, ladies and gentlemen? And I'm telling you, I'm sitting here and I'm not comfortable that we're not capturing this information.
Which specific are you not comfortable with?
That we're not capturing the information. You specified L&D. Do you have anyone in that unit that's supposed to be there monitoring this system that's not there during the 8 hours that they should be there?
On L&D?
No,
Or
not
you have
on
a
the
specific-
L&D, in material management. You see, when we sit and play the games, just know that 9 out of 10 times when I ask a question, I have the answers to it. Just know that.
Sure, so I know what you're
So
speaking
the
of.
employee, I expect that you all will be accountable for every employee at the hospital and performing their duties. And if we have anyone that's signing in and leaving for most of the day and then coming back in the afternoon, and we can't capture this information, I definitely have a problem with that. Are all your employees within material management full-time employees, and what are their work hours?
So thank you, Senator, for the question. I can speak directly to what you're asking about. You're talking about the supervisor of materials management, who, because what we want to do is make sure we have enough management throughout the entire day, but also the evening. That person has agreed for the last several years to work a split shift. So they come in at 6 in the morning, they work till 10 a.m., they punch out, he goes to a different job, he comes back, and then works another 4 hours into the evening. That way, we have a better coverage of management, for materials management throughout the facility. So if you're getting information that somebody is not working their assigned hours or assuming that they're being paid for that, that's inaccurate information.
So what are the other 12 doing? I didn't say that they're not working, but during the hours that this information should be captured is what I'm asking. So where are the other 12 employees that we can't capture all this information in a timely manner?
Well, the other 12 employees wouldn't be responsible for that type of information because it's supposed to be automated. And that's what the work is being done between the finance team and the nursing team, because they have to sit down and we have thousands and thousands of pieces of supplies on a daily basis. And we have new supplies coming in, we have old supplies coming out. This is a fluid situation that you have to have eyes on at all times. The other 12 to 13 individuals you're talking about, some of them work at our off-site warehouse, some of them are delivering supplies throughout the facility and managing that inventory. Some of them are dedicated to surgery, because surgery is supply intensive.
Thank you, Mr. Chair.
Thank you, Vice Chair Gittens. I see our Senate President. I know he's in and out of meetings, but he's back with us. So, Senator Francis, you're recognized for your 8 minutes.
Thank you very much, Mr. Chair, and good afternoon, and thank you for your testimony thus far. I've been in and out, attending various meetings, as just came from the University of the Virgin Islands. So if I ask a question that I've already been asked, just say asked and answered, and we could move on, so that we don't waste too much time. So in respect to the cardiac center, I wanted to know is there an update in terms of when the cardiac center will be reactivated?
I can't give you a date on that. What we did is we've already brought in 2 different companies to evaluate the interventional cardiac equipment has been down for probably 5 to 6 years at least. So you can't just turn that thing back on. It needs some reverberation. So we've had 2 companies already in, provide us quotes. That doesn't guarantee that it can come back on. So we've done a couple things. As we got those quotes, we're evaluating which one we're going to go with, but we've also applied for a grant that in case we can't get it back up and running, we can replace the whole thing.
So what is the priority level given to the reactivation of the cardiac center? Is this top priority for your administration at this time in getting that going?
We have a lot of top priorities. Again, going back to, I would say, Senator Gittens' frustration about the timeline of getting out of JFL Maine to tear it down. We have a top priority of getting the outpatient radiology and lab out of there so that we can tear down that building. So that is a top priority. But it also involves, the cardiac center is a big part of that to get that up and running. So it is very crucial to our operations.
Okay, we'll move on from there. The design of the new facility, have we completed the design or architectural design and construction plans for that yet?
Yes, we have completed. Good afternoon, Senator. Yes, we have completed.
Second?
Yes, we have completed the designs.
Okay, and is that public at this time?
It's part of the solicitation that we have ongoing right now.
Okay. So you have not, when will that become public? Is there a public review, or how do you then present that to the public?
So when you start, okay, you're asking for a timeline. I believe the solicitation is for 45 days right now. Part of a project of this magnitude is what we call value engineering. So even though you have the design, once you select a contractor, you then go through some value engineering to see how you can get speed to market to get the project done sooner. So I would say 60 days barring any questions or concerns with the solicitation.
Very well. And if we could just quickly go over to recruiting. I heard my colleague ask about the recruiting, and we have 2 recruiters on board right now. How many individuals have been hired or brought to the table by these recruiters?
Dr. Mavis Matthew, could you answer that question, please?
Yes, good afternoon. Sir.
Good afternoon.
In the past year, we recruited about 5 physicians, hired them. The newest recruiter was just onboarded within the past 2 weeks. So we don't have any activity in that regard. As I previously mentioned, her designation is going to be working with the J-1 visa process, as well as the National Health Manpower Shortage designation.
So this recruiter will be tasked with just physician, or you're also looking for nurses and other allied professionals?
This recruiter is just physicians. The other recruiters are for nursing.
The other recruiters for nursing, this one that you spoke about that just came on board for the last 2 weeks, is just for physician?
Yes, Senator.
Okay, very well. So for the nursing recruiter, how many nurses have we been able to hire with that nursing recruiter?
Please go ahead.
Doris Plaskett, Chief Nursing Officer. Right now, we do not have a designated nurse recruiter. We do have a hospital recruiter that recruits for nursing and other hospital employees.
Okay. All right, I'll move away from that. I thought that, in fact, they said the other recruiter was responsible for recruiting of nurses, so that's not the case.
No, what was testified is that there are 2 physician recruiters, one focus on the locum and the tenants, and the other focus on recruitment of permanent physicians.
Okay. On the graduate nurses program, I saw that you mentioned that you have you brought on 10 of 14 of those individuals. How many do we still have on board?
I'm sorry, can you repeat the question?
In the graduate nursing program, in your testimony, you mentioned that you had picked up 10 of 14 of those in 2022, 8 in 2023. I'd like to know how many do you still currently have on board, or you have now transitioned into the RN phase?
So for the numbers that you mentioned in 2022 and 2023, they all have passed the nurse licensure and examination and are currently working as registered nurses.
So you're able to pick up all 10 of them from the 22 and then the 8 from the 23?
Yes.
Okay, that's great. That's good news. And what are we doing to try to bring back home some of those nurses that we lost? We know that we have a lot of nurses that have since left the Virgin Islands for the purpose of either better paying jobs or other opportunities. how are we endeavoring to reattract those nurses back home to the Virgin Islands?
So I think one of the most important things that we have been able to address that will make a difference, and that is the negotiation of the salaries. Just having a more competitive salary and benefits will address a lot of the challenges in regards to recruitment of off-island nurses.
And we have closed the loop on the salaries, right?
Correct. We have concluded negotiations with the LPNs, the RN, and the RN supervisory unit.
So what other areas are they interested in? I mean, of course,
1 minute.
housing, transportation, and those other issues are also part of the needs. So how are we trying to meet them halfway in those type of concerns?
We do offer relocation benefits, and I know we have had discussion about sign-on benefits as well, so that may be something that we offer in the future. One of the other things too is providing career advancement and development, especially in the specialty areas, so that for the nurses that would like to go into a specialty area that they don't have experience, we do offer a training program that we allow them to be mentored into different areas that they would like to gain experience.
Quickly before my time run out, I know that you spoke about your almost 1 year anniversary and moving into the JFL North. And I would imagine there have been some growing pains in that transitional phase. Have we been able to address the water, energy, generator situation? I know that from time to time we've been hearing some complaints about those situations. Have those been corrected?
So I'll start with just more the operational issue. I think the biggest growing pain is going from a 250,000 square foot down to 52,000 square feet and giving up, not having space for storage in all those different areas. Daryl, can you touch on the infrastructure?
Senator, you referred to water challenges or generator issues. I'm not aware of any water or generator issues affecting JFL North.
Okay. Well, we had gotten some calls some time back in regards to insufficient water levels, and there were some issues in terms of getting the water into the facility. We heard about one of the generators that had dysfunction during a WAPA outage that required an extended period of time to be reactivated. Those are some of the things that I've heard about. You're saying that you're not aware of those?
Again, Senator, I'm not aware of it on JFL North. I'm not wondering if that's JFL Main. I know there was a generator issue sometime back at JFL Main, but not JFL North.
Mr. CEO, are you aware of any such thing happening?
Specifically to what you're asking about, water issues. So we did go through a period of time where we switched water vendors because for a variety of different reasons. That caused a little bit of delay. We never were at risk of running out of water. It just became more of a timing issue from that perspective. Related to the generator, I was actually on site 4 in the morning, I think, when that happened. And it was, we only have one generator for JFL North, which we have an active plan to put another one in. But that's what caused the outage, and we make sure that generator is properly tested and maintained.
Okay, Mr. Chair, I just got 2 more quick questions, if you'll allow.
Yes,
What about oxygen? Are we also address the oxygen situation? I heard that at one point, again, we were low in having oxygen available for patients. Have that been addressed?
In a recent past, we have not had oxygen situation, a supply issue. We have a great relationship, and I want to thank Carib Supply for all their work as we transitioned away from JFL Main to JFL North. We've been consistent with our oxygen supply.
Okay, and my final question, again, going back to the THRT team, with this whole notion of the bundling that's being done currently by ODR, what is the collaboration, or how will then the THRT team work in conjunction with those individuals that we brought in or be considered for these bundling?
Well, yes, Senator. I am working collaboratively with the ODR team. The THRT will continue to exist because of the expertise in the healthcare arena, and I will continue to be a liaison between the two.
Thank you. Thank you, Mr. Chair, for the time. Thank you for your responses.
Okay, thank you, Senator Francis. Director Cook, couple questions. So you said the accounts payable now is about 20 million minus the IRS, right? How about your accounts receivable? I know you got a 7 million for Medicaid. You said you're getting paid from labor. How about your patient? How does that look?
Chris will be able to answer that question for you.
Chris, yeah.
Okay. Just give me 1 second to bring up my ARs.
Okay, well, while you're looking for that, WAPA, let's go to WAPA. So, do you owe WAPA any money, and is it be taken out from your allocations and directly paying WAPA? How is that being processed?
Yes, we have a allocation that's, or an amount that's taken out of our allocation on a monthly basis that goes directly to WAPA. Unfortunately, now that we're running two campuses, or two facilities, JFL North, and we still have to maintain JFL Main, our energy costs are exceeding that amount. So we are racking up a deficit with WAPA, which we understand we need to take care of. But we do have a deficit there.
A deficit like more than $1 million, ballpark range. You got those numbers now?
It's right at approximately $2 million we owe WAPA.
Okay, 2 million. Okay, can you give me the other numbers now on the accounts receivable with the patients?
Yes. Did you want to know by payer or by overall numbers?
Overall, yeah.
So overall, it's a grand total of $77 million, but that's a little convoluted because that's including the entire open amount that was billed and what's still hanging in the adjustments. Out of that, I could do a payer breakdown as far as what we expect for collections.
Well, no, I just wanted, so 77, that's age, what's the last date?
The last date?
Yeah, I mean, what's the earliest date?
Oh, this would go back to 2019, excuse me, when we wrote off everything from 2019 in our books.
Okay. So what is the patient portion again? Give me that number.
Well, for the patient, the self-pay is closing at 25 million.
25. How about Cigna? Is Cigna on that list?
Yes, Cigna's closing at 2.8 million.
2.8. What are your other major insurance carriers you have?
Our biggest ones are obviously Medicare, Medicaid, where Medicaid is closing at 18.9 and Medicare is closing at roughly 24 million.
Okay, thank you. Quickly now, let's go to the staffing. So, what's your total staff, total nurses, total doctors?
I'll address that to Patricia Canagata from Chief of HR.
Yes, Ms. Pat Canagata, can you give us your total staff, total nurses, total doctors?
Good afternoon, Senator Patricia Canagata, Chief of Human Resources. We have over 500 employees. Physicians is about 30. I'll defer to Darius Plaskett for the nurses because that's changing rapidly. CNO Plaskett?
Currently, for the total inpatient nurses, we have a total of 80 registered nurses. We also have a total of 8 LPNs. This does